first pranam to our teacher and Guru Padma Shri Dr. T.P. Lahane. Sir, will you please say a few words and inaugurate this webinar of Gurukul, which is just the most apt thing because we are all your students here today.
Good morning, everybody. I welcome you all for the Gurukul concept of Bombay Ophthalmic Association. I appreciate the Swapnesh and Pritam. I welcome Karobi and I think the Grant Medical College is doing the ophthalmology department in the Regional Institute of Ophthalmology and doing a great work in the teaching and also in the treating the poor and needy patient of all over Maharashtra. This concept which is brought by the Swapnesh and Pritam is the best concept where we can teach the students and they can see live whenever they have got the time. And all the students who have passed from the same college alumni are taking part in that. I welcome all and wish them all the best on the Teachers' Day. And I request all that in our life we must be serving the mankind, and our motto should be that everybody should have the vision. We are there to give the vision to the people who are poor and needy, who are blind, and we must be able to remove the preventable blindness and also educate the people. So with best wishes and thank you, Ragini.
Good morning, sir. Good morning, Ragini. Nice to see you.
I love you, Ma. Happy Teachers' Day.
Same to you. Same to sir.
Happy Teachers' Day. Happy Teachers' Day to sir, madam, everyone.
Hey, PP, how are you?
Very good.
Dr. Pritam, would you like to say a few words? Then Swapnesh and
yeah.
Karobi ma'am, would you like to say a few words? You are the senior teacher after Dr. Lani sir in this gathering.
I appreciate this initiative that you people have started. That is Pritam, Ragini, you, sir, and Swapnesh. Swapnesh is the spearhead for all this, and this is a very beautiful initiative, and it aids so much of learning, and it brings about a closeness in all the alumnus of the JJ and all the regional institutes. This is a very novel thinking idea that you all have proposed, and I wish you all the best for the future seminars.
Thank you, ma'am. Dr. Pritam.
Yeah, so, first of all,
congratulations on continuing as the president of the Bombay Ophthalmic Association.
Thank you, ma'am. Thank you. Thank you. Thank you. First of all, a big, thank you to Lahane sir and Ragini madam for allowing us to do this Gurukul concept. And a big thank you to Swapnesh because he has actually conceptualized it. So, so thank you, Swapnesh, for coming up with this idea of Gurukul. I think with this, we are essentially going back to our roots, to our alumni, to our teachers, whom we owe all our success to our teachers in one way or the other. So we are going back to our roots and we are again learning from them. I think there is nothing greater than that. So with that, we let's start with the first day today.
Thank you, Pritam. And just a few words from Swapnesh. So this was his brainchild a few days back. He said that, can we have this? And I think he comes up with these fantastic ideas. And I think he is blessed from his guru, Dr. Lane sir, Pritam, Karobi ma'am, and everybody in BOA. Swapnesh, would you like to say a few words? And then as Dr. Pritam said, that we can begin. And we are, like Pritam said, that we are really blessed that whatever JJ is today is because of the hard work of Dr. Lane sir, who encouraged all of us. And I'm so happy that Karobi ma, my senior from JJ, my mother, and all of us are going to be here today. Swapnesh.
So thank you, madam. First of all, my respects to my first guru, Dr. Neeta Shanbag, under whom I passed my ophthalmology. After that, I came to JJ and I was standing beside Dr. Pritam sir and asking him, where is the vitreous? I can't see it. So he was my second guru. Later on, I went to Shankar Netralaya, and I would take this opportunity to say a happy birthday to Guru for me, Saili, and Pritam sir, Dr. Pramod Bhende sir. Post SN, I actually found Guru, philosopher guide in Dr. Ragini madam and Dr. Lahane sir, who helped me shape my skills and Preetham sir for giving a free hand, and also Dr. Anand Subramaniam for giving me a free hand to improvise my skills. So I think this day is an apt day for all the students to give a homage to all the gurus. And so concept and all is fine, but during this tenure, I found Madam and Preetham sir both means nurturing our ideas and taking it forward. So it's actually their kind of idea to promote whatever we are bringing on to the BOA platform so that it is shaping so well. So with that, I think we should start with our first lecture. Preetham sir, would you please invite the first speaker?
The first speaker to start is Associate Professor Dr. Saili Lahane. Saili is right now, the heart of the Retina department at JJ Hospital. She is a alumnus of obviously JJ Hospital, as well as she is a Retina alumnus of Shankar Netralaya. So Saili, welcome to you. And Saili is going to speak on her topic for today is macular hole, how to improve the outcomes. So Saili, you can start sharing your slide.
Yes, sir. Thank you, sir. At the outset, I would like to thank BOA for giving me this opportunity. And I would like to wish Happy Teachers Day to all my teachers, sir, madam, Preetham sir, and everyone, Karobi ma'am, all my teachers.
Happy Teachers Day to you too, Saili. You are a fantastic teacher.
So for all the speakers, we have about 12 minutes for each talk. So we'll try and stick to our time. So probably we can have, a little fruitful discussion. Swapnesh, we can initiate the discussion after every talk or maybe at the end of the session as you wish.
So at the end of the session.
Okay.
Okay. Are the slides visible?
Yes, yes.
Good morning, everyone. So today I'll be speaking about macular hole. So macular hole is a full thickness neurosensory retinal defect involving anatomic fovea and primarily the foveola of the eye. NAC first reported a case of trauma-related macular hole in 1869, and this term was proposed by Ogilvie in 1900. J. Donald M. Gass revolutionized the concept of vitreous theory. So, most common etiology of macular hole, it is commonest cause is it's idiopathic. We don't know why this macular hole happens. Other causes could be trauma, high myopia, then cystoid macular edema, proliferative diabetic retinopathy, severe hypertensive retinopathy, CNVM, and solar retinopathy. It's classified as primary macular hole, which is commonly idiopathic, and secondary, which could be caused by other pathologies which are not associated with VMT, like blunt trauma, high myopia, and different causes of macular edema. So most common is idiopathic macular hole. There are many pathogenesis which have been, there are many theories of pathogenesis of macular hole, like traumatic theory, cystoid degeneration theory, angiospastic theory, or vitreous theory. Currently, the pathogenesis is thought to be oblique or anteroposterior traction, which is caused by persistent vitreofoveal attachment following perifoveal vitreous separation, tangential vitreoretinal traction, predisposing involutional changes in the inner layer at the fovea. So Gass has classified macular hole as stage 1A, which is an impending macular hole where there is loss of normal foveal depression, and it is associated with development of a yellow spot. Pseudocyst. So there is a pseudocyst, which is basically inner layers of the retina that detach from underlying photoreceptor layer with the formation of schisis cavity. So stage 1A is similar to a foveolar detachment. And stage 1B is an occult macular hole where we see a yellow ring with patients complaining of metamorphopsia or mild decrease in visual acuity. In this, the pseudocyst has progressed to outer foveal layer, causing the separation of those layers. And this can also simulate a foveal detachment. So this is the OCT picture of stage 1A, where you can see this pseudocyst-like formation and the vitreous which is attached to the fovea. And in the stage 1B, the hole has progressed to outer layer. The hyaloid is still attached. In stage 1B, it's a small or early full thickness hole. which the size of which is less than 400 microns. This may be central or eccentric or crescent shape. A dehiscence develops in the roof of the schisis cavity, but the vitreofoveal adhesion is persistent. So this is a stage 2 hole where there is a full thickness defect and the vitreofoveal attachment is still there. In stage 3, it's a full thickness macular hole which is more than 400 micrometers in diameter. On fundus appearance, it will appear as a red base with yellow-white dots. There could be a surrounding cuff of SRF. Avulsion of the roof of the cyst with an operculum and persistent parafoveal and optic disc attachment of the vitreous cortex. So here, the roof of the cyst is avulsed, but the vitreous is still attached to the optic disc. So there is no complete PVD in stage 3 macular hole. In stage 4, it's a full thickness macular hole with complete PVD. It's more than 400 micrometer in size, and the posterior vitreous detachment is seen as a vise ring in these patients. So here there is a totally detached PVD, and this is a stage 4 macular hole on OCT. The clinical features of macular hole are metamorphopsia, mild loss of central vision. Full thickness macular holes can be diagnosed with the help of slit lamp biomicroscopy or Vascular Island test, laser beam test, OCT, autofluorescence. FFA also can show macular hole, but it is not indicated as an investigation for macular hole. So on the slit lamp beam microscopy, the patient will observe a break in the beam when it is centered over the macular hole, and this is called as Vascular sign. Then 50 micrometer laser beam test. Here what we do is we direct the 50 micrometer aiming beam of an argon laser at the hole, and the patient with a true full thickness macular hole may note a disappearance of the aiming beam in the hole. Patients with epiretinal membrane and pseudo hole will still see the aiming beam. A more sophisticated analysis of the absolute and relative scotoma can be done with the help of macular microperimetry. FFA usually not indicated for diagnosis. It will demonstrate a window defect with early hyperfluorescence in the area of neurosensory defect. B-scan, it's not for diagnosis. It may just help in predicting the vitreomacular relationship. Other types of hole other than idiopathic holes could be traumatic holes, and in these traumatic holes, the factors which are favoring surgical intervention would be young age, recent or short duration, smaller size. So if we see smaller size holes and recent duration holes, then they might have a good prognosis. In myopic holes, patients with very high myopia may have foveal schisis, posterior staphyloma, and there will be a chorioretinal atrophy at the macula, and these holes are very difficult to do Ilm peeling because the contrast is very poor in these patients. Other types could be post-CME, like following diabetic macular edema or post-venous occlusions or uveitic macular edema. So these are some holes which are post-cystoid macular edema. Differential diagnosis could be cystoid macular edema, solitary drusense, epiretinal membrane, lamellar macular hole, exudative maculopathy, central serous retinopathy, and age-related macular degeneration. So what is the treatment? Stage 1 has 50% chance of spontaneous resolution. So usually stage 1 with no decrease in visual acuity, we can observe closely these patients. Surgery is considered in stage 2 to 4 full thickness macular hole. Surgery of choice is pars plana vitrectomy with Ilm peeling, maybe conventional Ilm peeling or inverted Ilm peeling with gas tamponade. Gas could be C3F8 or SF6. So these are AAO recommendations of macular hole. So stage 1A and 1B, it's usually observation, call the patient every 4 to 6 months or prompt return if there are any new symptoms. And stage 2, 3, 4, it's usually surgery. I'm sharing a video now. So when we are doing macular hole surgery, first we have to, it's 23 gauge pars plana vitrectomy. We can use triamcinolone for PVD to assist the PVD induction so that PVD is induced properly. Then for staining of the Ilm, we can use different types of dyes. ICG was used earlier, but it was found to be very toxic, so it's not used very commonly. Now we use brilliant blue more commonly to stain the Ilm. Now you can see Ilm is being peeled with the Ilm forceps. In conventional Ilm peeling, we peel the Ilm towards the macular hole, not away from it, so that inadvertent increase of the macular hole size of macular hole doesn't happen. And the peel is from arcade to arcade. And in inverse Ilm peeling, what we do is We peel ILM, and a part of ILM, we keep it attached to the macular hole, to the edge of the macular hole, and the remaining macular hole is peeled. The remaining ILM is peeled conventionally from arcade to arcade until the optic disc. And that small flap is then deposited in the macular hole so that it acts as a scaffold for helping the hole closure. Here also you can see in this video, a small flap of the ILM is being made at the edge of the macular hole. Staining with brilliant blue actually makes it very easier to identify the ILM. Now, to peel the ILM, we can either start by pinching with the ILM forceps, or sometimes we can use a long 26 number needle, which is 1.5 inches, that can be used, or we can use a membrane scraper, so that with this membrane scraper, it's very atraumatic. With that membrane scraper, we can just scrape and remove the ILM. After we have removed the ILM, and if we have inverted the flap, very slowly and gently, we have to do FGE so that the flap is not displaced. And after the FGE, FGE means fluid gas exchange, and after that we inject C3F8. So post-operatively, we advise a patient to maintain prone position for at least 2 weeks. Inverted ILM flap was first described by Nicholas et al. In 2010, and it is used for treating large idiopathic full thickness macular holes, as well as it's useful in myopic holes. They have the authors have shown that it increases their rate of complete macular hole closure from 88% to 98%. 88% was the closure rate with conventional ILM peeling, so it has increased to 98% with inverted ILM flaps. Dyes which we use is endocyanin green, but it is very toxic, so it is not used. Trypan blue can be used. Triamcinolone acetonide is used for staining the residual vitreous, and brilliant blue is an excellent stain for ILM, and it is relatively non-toxic. Other biological adjuncts which have been used in macular hole are TGF-beta or autologous serum, autologous platelet concentrates, thrombins, and fibrin mixtures. These have been tried when the macular hole is not closing. It is persistent even after first surgery. So these adjuncts can be used for closing the macular hole. To indicate the prognosis of macular hole, we can use hole form factor. In hole form factor, it is here in this diagram, you can see A is the base of the hole, C and D are the right and the left arm, and B is the minimum diameter of the hole. So in hole form factor, what we do is C plus D divided by A. So base is at the denominator. So if the hole form factor is more than 0.9, 80% closure rate is noted. And if the hole form factor is less than 0.5, then the success rate reduces to about less than 25%. So if a macular hole is larger than 300 to 400 microns in the diameter, the closure rate is reduced. And even if the hole can be closed, the final visual acuity is often not good. Hole form factor more than 0.9 indicates a better prognosis. And these holes anatomically tend towards type 2 closure. So type 1 closure is without any neurosensory defect. So this you can see pre-surgery, there is a macular hole, stage 3 macular hole, and post-surgery, the hole is closed without any neurosensory defect. This is type 1 closure. And here you can see this is a full thickness macular hole, type 4 macular hole, stage 4 macular hole, and post-surgery you can see the hole is closed, but there is a neurosensory defect. So the visual outcomes with this type 2 closure will be lower. So in summary, only 40% progress from stage 1 to stage 2. So in stage 1, we can observe the patients. About 67 to 96% progress from stage 2 to stage 3, 4. That's why if we see a patient in stage 2, it's usually better to operate these patients. Fellow eye has 29% chance if there is no PVD. So in 2 years, he has 29% chance of developing a macular hole, and less than 5% chance if he has already developed PVD in that eye. So the 5-year risk in fellow eye is about 10 to 15%. That's why it's very important to check fellow eye of these macular hole patients and keep them in follow for the other eye. Thank you so much. I thank all my teachers on this Teachers' Day. I would like to wish them happy Teachers' Day. Thank you so much.
Thank you, Dr. Saili. That was a very crisp and nice presentation, telling all the aspects of macular hole, its pathophysiology, its features, its treatment, latest surgical techniques. While we maybe discuss few things, I would like to invite the next speaker, that is Dr. Ashish Jain. Dr. Ashish Jain also is an alumnus of JJ Hospital as far as his retina fellowship is concerned. He was an exemplary vitreoretina fellow, very hardworking. He was the fellow who never says no. Everything that you ask him, tell him is always a yes, I'll do it, sir. And he was one of the first fellows. So when we started retina fellowship at JJ Hospital, we were also we had teething troubles. We were wondering what we are supposed to teach the fellows, how to guide them. He was one of the first fellows, and now he has joined the department, and he's now a part of the teaching faculty of vitreoretina fellowship at JJ Hospital. So Ashish, welcome. And your topic for today, you're going to talk on vein occlusions, a very important medical retina topic. So you can start sharing your slide. While Ashish is sharing his slide, maybe any comment on the macular hole, Dr. Korobi, any comments while Ashish is sharing his slides?
Suresh Ramchandani has also joined. Hi Suresh, happy Teachers Day.
Hi, Suresh.
Hi everybody. Yeah. Hi Ragini.
Hi.
Hi Swapnesh.
Hello sir.
Okay. So
That was a nice presentation.
Ms. Karobi ma'am, Lane sir are also there.
So can you see my slides?
Yeah, Ashish has come.
Okay. So
No.
maybe you can start, Ashish, then we'll take all
Yes, sir. So thank you very much, Ragini ma'am, Lane sir, for the wonderful opportunity, Swapnesh sir, and my mentor at JJ, Preetham sir, and Saili ma'am, all my teachers here. So happy Teachers Day. I start my talk on vein occlusions. So retinal vein occlusion is the second most common retinal vascular disorder after diabetic retinopathy. It usually presents with acute unilateral painless loss of vision. On the basis of the location of the occlusion, it can be classified into major two types: a central retinal vein occlusion and a branched retinal vein occlusion. It is very common to see a occlusion patient in the OPD, and the management is some of the first pearls that we learn in a medical retina OPD. So starting with the branched retinal vein occlusion, this is a vessel occlusion with the prevalence of around less than 0.4%, although we can again classify into it as a major BRVO or a macular BRVO depending on the location of the occlusion. It is most commonly seen in the superior temporal quadrant, as we see a lot of AV nicking in that area, and hence it is more prone for occlusion in that area. We'll start with the risk factors of any vein occlusion. So for a branched retinal vein occlusion, the majority of all cases, that is around more than 90% times, we see is a AV nicking. What is AV nicking? Basically, it's a crossing over of the artery over the venule, and that helps in the compression of the venule, causing its occlusion. That is why we see all the vein occlusions are most commonly, branched vein occlusions are mainly at the AV nicking. So the factors which help in this AV nicking, the normal AV crossing, as you can see in this diagram, there is not much of compression of the venule below. But in the nearby diagram, you see there is the compression which is caused by the various factors which include hypertension, arteriosclerosis. The other most common risk factor also can be age, because all the vein occlusions are most commonly seen in the 6 to 7 decade of life. The other cardiovascular risk factors include diabetes, smoking, hyperlipidemia, atrial fibrillation, renal dysfunction, and atherosclerosis. So in these risk factors lie the investigations that we advise to the patient whenever they come in the OPD with a branched retinal vein occlusion. Moving on to the other risk factors, in a young patient, when they don't have any systemic risk factors, we go into inflammation or infection. The most commonly that we see are hypercoagulable states, which include inherited condition or acquired condition, which can be factor V Leiden mutation, protein C deficiency, protein S deficiency, hyperhomocystinemia, which is very commonly seen, and anti-cardiolipin antibodies or APLA syndromes. Moving to the pathogenesis, as I told you, it's mainly because of the interruption of the venous flow, which almost always occurs at the AV crossing. This compression can occur from mainly three reasons. One is the external compression of the vessel wall of the vein with the artery. Second is the degeneration of the vessel wall because of lipids or plaques which form. And third is hematological abnormality, which causes to throw a thrombus along the blood vessel, which gets blocked because of the narrow lumen because of the AV nicking, and hence causing the compression. So three main causes pathogenesis of BRVO. One is mechanical compression. Second is degeneration of the vessel wall, which also include thickening of the endothelium and narrowing of the lumen. And third is hematological abnormalities. Moving on to the clinical features, the symptoms the patient will generally present with a painless acute sudden loss of vision, or he may also present as asymptomatic and could be incidental finding if the macula is not involved. Seeing the signs include blood splattered retina. We see multiple flame-shaped hemorrhages and dot hemorrhages. Depending upon the location of the occlusion, the hemorrhage will be scattered in those quadrants. So generally, if we are seeing in this picture a right eye showing occlusion at the superior temporal, we see a AV nicking where the venule has been compressed, and beyond which we see the hemorrhage splattered in around 2 to 3 quadrants. Sometimes we also see called as macular BRVO, in which only a small tributary vessel is occluded and it causes hemorrhages only in a single macular quadrant, and is also called as macular BRVO. The other signs and symptoms can also include cotton wool spots, it can include macroaneurysms, and we can also see the dilated tortuous vessels which can be seen occluded beyond the point of occlusion. These are the signs that we see clinically in a patient of BRVO. The complications are the ones which causes the decreased vision in a patient with BRVO. So three main complications that we need to remember. The most common vision threatening complication of BRVO is macular edema. Second is macular ischemia, and the third is a sequelae of neovascularization. So first, moving on to macular edema, it is the most common cause which causes swelling, inflammation, which is caused due to the hypoxia of the retina, which causes increased VEGF, and that causes the swelling of the macula, the foveal layers, and causing macular edema. Macular ischemia because of the chronicity of the occlusion, decreased blood flow, and hence it causes the enlargement of the foveal avascular zone, hence causing macular ischemia. Macular ischemia is the most common cause of delayed. Even when the macular edema has resolved, we see that the patients are not getting useful vision is because of macular ischemia. Sequels of neovascularization in patients of BRVO who are left untreated or inadequately treated leads to increased VEGF production, and that causes the neovascularization, which causes the complication of vitreous hemorrhage or tractional retinal detachment. So three major complications of BRVO. Moving on to the clinical evaluation, the first clinical evaluation that we learn is in the OPD on clinical examination, because BRVO clinically is very well documented, and using an indirect ophthalmoscope or a direct ophthalmoscope, we can see the area of hemorrhages throughout the quadrants beyond the occlusion. Also, we will see cotton wool spots or macroaneurysms. Investigating a BRVO, the first and most useful investigation in BRVO is a optical coherence tomography, or the OCT. OCT helps us to see if there is macular edema. As you see in this picture, we see there is macular edema involving the outer plexiform layers, causing a macular edema, and hence the vision will be decreased in this patient. And beyond this, if we also see, we can see in chronic cases, we see loss of the RP layers in the OCT, or disruption of the IS-OS junction, and that causes decrease in the vision in many patients of BRVO chronically. Moving on, the investigation further that we do is a fundus fluorescein angiography. Fundus fluorescein angiography in the acute stages is not a very helpful investigation because of the block fluorescence, because of the hemorrhages that are splattered throughout the retina. So generally, a fluorescein angiography will be done when the hemorrhages have resolved, and we want to see if there are any capillary non-perfusion areas or any neovascularization. So on a fundus fluorescein angiography, what we see is the delayed filling of the venule beyond the occlusion. If it is beyond 2 to 3 months when the vein has perfused again, we might not see that delay. The other findings that we see on a fundus fluorescein angiography is the block fluorescence because of the hemorrhages, as you can see in this picture. The next finding we can see is the capillary non-perfusion, which is seen in the bottom part of this picture. If we see, capillary non-perfusion is a very important finding, which was the basis on which the DVO study had described ischemic and non-ischemic BRVO. Greater than 5 disc diameter of capillary non-perfusion areas was termed as ischemic BRVO, whereas less than 5 disc diameters of ischemia was termed as non-ischemic BRVO. In this picture of FA, we see multiple spots of hyperfluorescence which are increasing in size and intensity, hence giving the finding of neovascularization, as we can very clearly see in this picture. This is the early phase on the left side of the screen, and the right of the screen we see the increase in the size and intensity. Also, we can see the laser marks behind, which has caused staining of the retina, of the staining hypofluorescence. Next, a very useful and innovative tool, which is very useful recently, is the OCTA. OCTA being a non-invasive test, it gives very good results, not only of the superficial layers, but also of the deeper layers of the retina. OCTA can give us useful information. When we see in this picture, this is a 12 image montage of a patient with a IT BRVO. This is a OCTA which was taken around 3 months later, and hence we can see very clearly how there is so much of loss of the FZ in the along that quadrant. We see capillary non-perfusion areas. Also, we see NVEs which have developed inferiorly. So OCTA forms a very important part, not only in the initial evaluation, but also in prognosticating the patients with BRVO. In this patient, as you see so much of macular ischemia, we can easily tell the patient will not have a very good vision. Also, the deep capillary plexus and the choroidal layer in the OCTA helps us to know whether the perfusion is in the deeper layers or not, because the deeper layer, deep capillary plexus in the OCTA is supposed to be at the watershed area of the nutrition and more susceptible to ischemia. And the deep capillary plexus, sometimes we see in a patient of BRV that the OCT shows no edema. Still we see there is decreased vision. Why is that? Because the deep capillary plexus has had ischemia and there's loss of cells in that area. Moving on to the treatment. The treatment earlier, as told by the BVA study, strictly focused on laser photocoagulation, but with the advent of anti-VEGFs in around the 2000, we've had significant change in the treatment modality. So in a patient with macular edema, initially at presentation, we would like to go with anti-VEGFs. Anti-VEGFs, broadly, we can divide it into 4 anti-VEGFs that we know. That is bevacizumab, ranibizumab, aflibercept, and Piconex. And most commonly that we use in the OPD is the first 3, that is bevacizumab, ranibizumab, and aflibercept. The second treatment that we give is laser photocoagulation. Laser photocoagulation is to decrease the hypoxia of the avascular retina and hence decrease the VEGF load. So a definitive treatment and should be done. It can be supplemented by the FA images where we see a lot of capillary non-perfusion areas and hence a sectoral PRP involving the area, the wedge area where there is ischemia. The laser photocoagulation acts as a very important treatment part. The other experimental treatment which were studied earlier but not proved with much efficacy was systemic anticoagulation. Other was vitrectomy with sheathotomy. It has been seen that the adventitious sheath was shared between the artery and the venule, and vitrectomy inducing the PVD or decreasing the pressure or gentle massage at the AV nicking could help dislodge the occlusion and hence help with the treatment part, but not done very commonly. There are multiple trials in BRVO in relation to the treatment part. The SCORE and Geneva study studies the effect of corticosteroids in the treatment of macular edema for BRVO. SCORE studied the comparison of IVTA in BRVO and saw a very good improvement of more than 2 lines. And Geneva was a similar study done with Ozurdex, which is a 0.7 milligram dexamethasone implant. The other trials, including anti-VEGF, was Bravo study, which studied the effect of ranibizumab, the Horizon trial, the Vibrant trial, which saw the effect of aflibercept, and the Marvel study, which is ongoing and seeing the effect of bevacizumab, because bevacizumab is an off-label use for BRVO, and hence there are not many studies which support the use, and Marvel study is one of them. So just an outline of the trials in BRVO. Moving on to the central retinal vein occlusion. So central retinal vein, yes, sir.
We are a little want of time.
Okay, sir.
So if
Okay,
you
sir.
can little bit,
Sure, sir. Sure.
Conclude.
Sure, sir. Okay. So central retinal vein occlusion is the occlusion which is happening at the area where there is a common artery and the venule. It can happen at the plane of lamina cribosa. Mainly classified into ischemic and non-ischemic, depending upon the better visual acuity is non-ischemic, and ischemic is with a lesser visual acuity, with a more hemorrhages and with a worse prognosis and more complication of neovascularization. Moving on to the evaluation of BRV and CRV almost falls into the same. That is the OCT to look for the macular edema, followed by angiography, which shows blocked hyperfluorescence. Also, we see NVEs and capillary non-perfusion areas. And OCT, as I told you, will give the same pictures of non-perfusion and enlargement of the FAS or capillary non-perfusion areas. The treatment also lies in a similar manner of anti-VEGF and laser photocoagulation. Anti-VEGF for the macular edema, laser photocoagulation to burn out the hypoxic area and decrease the VEGF load. There are multiple of experimental treatment modalities like chorioidal venous anastomosis using YAG laser. RTPA has been used recently with a 40 gauge needle. Vitrectomy in cases of resistant macular edema or complications of CRVO. Trials in CRVO are the SCORE and GENEMA studied the effect of corticosteroids. There is Cruz, Copernicus, and Galileo. Galileo is the latest study which shows the use of aflibercept in CRVO, and we are seeing many use of aflibercept recently. So this was a broad outline of vein occlusions of BRVO and CRVO. Sorry if I missed anybody. Happy Teachers Day, everyone. Thank you, sir.
Thank you, Ashish. That was a huge topic, but I think you've done justice to both the topics, branch vein occlusion and central retinal vein occlusion. Thank you. And moving on, our next speaker is Dr. Ashwin. Hi, Ashwin.
Hi, Pritam.
Dr. Ashwin is again a consultant at JJ Hospital. He is a fantastic teacher. He is a prolific surgeon, and he always has some new techniques up his sleeve. He's an innovator par excellence. He's an alumni of Arvind Eye Hospital, where he did his Retina Fellowship and then was there as a faculty also. So I welcome Ashwin. His topic for today is very important topic, approach to uveitis. So Ashwin, you can start sharing your slides.
Yeah, thank you, Pritam, for those kind words. And I wish to say thank you, POA, for this opportunity. And very happy Teachers Day to all the teachers out here. So everyone can see my screen?
Yeah, we can see it.
Okay, so basically, I'm just going to talk very basic approach to uveitis. Mostly, all of us are perplexed when we see a case of uveitis is what investigations to order. So the main focus will be to combine certain clinical scenarios with the investigation that can lead us to a proper diagnosis, which may be possible many a times than we imagine. So basically, I'm approaching a uveitis just like a Google search. So if you just ask for a Google search and you want Domino's pizza and you just ask Google, it will give you a lot of outlets. But if you put in some filters, like I want a Google Domino's pizza near me, then you will get the appropriate answer from Google as well. So this way, even a uveitis case requires proper filters to be put in so that you can arrive at a proper diagnosis, which will lead to a proper treatment for the patient. So basically, we should be aware about the classification of uveitis that can be anterior, intermediate, posterior, and pan-uveitis. This was classified by Sun Working Group. So I believe everyone is aware of what all organs are involved in that, and that's why I'm just not going into the details. The second classification proposed by them was depending upon the onset, whether it's acute, whether it's insidious or chronic. So all these factors have to be taken into consideration when you're seeing a case, because some cases may present only as acute anterior uveitis or acute uveitis, and some may be having a chronic course. So when we have that in mind, we can probably arrive to a better diagnosis. Secondly, and the most important clinical aspect that we should look at is whether the uveitis is non-granulomatous or granulomatous, because this will help you in actually ruling out causes in a way, and then come to definitive investigation, because each case of non-granulomatous or granulomatous uveitis will have specific set of investigations that you are supposed to give to the patient so that you can arrive to a diagnosis. So in a non-granulomatous uveitis, all of us are aware that the keratoid precipitates are small. They may be like a dusting on the endothelium. However, in a granulomatous uveitis, you may see findings like large KPs or medium-sized KPs with iris nodules or iris granuloma that you see here. So I have now tried to cover certain conditions which we see in a normal clinical day-to-day life, and try to get the investigation which will help you to get to a diagnosis. So ankylosing spondylitis, which we see commonly in males in 20 to 40s, has patient will typically have a complaint of lower back pain and stiffness. Remember that history is one of the very important way in which, in a case of uveitis, you can rule out a lot of causes. So history taking in a case of uveitis is very important. specifically you have to ask the patient leading questions, whether you have this or you don't have this, because those symptoms may be so subtle that the patient may miss those in their day-to-day life. And once you ask them, they say, yes, doctor, this is what I experienced. These patients may be HLA-B27 positive in 90% of the cases. And ocular finding that you will see is mostly unilateral acute anterior uveitis with a may be associated with hypopia. So mostly it is typically unilateral. Young patients typically unilateral having low back pain, you should suspect of ankylosing spondylitis, and then you can investigate him accordingly. Also, the typical sacroiliac imaging study will tell you about the bamboo spine appearance of the spine. Juvenile rheumatoid arthritis is not very commonly seen, but when you see uveitis in children, that is below the age of 16 years, and if the disease is more than 6 months old, you have to suspect that there is juvenile rheumatoid arthritis. There are various types of juvenile rheumatoid arthritis, which is pauciarticular and potiarticular. Pauciarticular is when the less than 4 major joints are involved. These pauciarticular cases have very poor prognosis. Most of the people who are at risk are those which are ANA positive, are rheumatoid factor negative, and pauciarticular girls. These uveitis, because of the chronic condition, the uveitis may be so subtle that it may not present before, but it may present as joint disease before. So they can be associated with various complications like band-shaped keratomyopathy, peripheral anterior synechiae, cataract, etc. Next, very important and very common, though we don't think it is that important, that common, but is a Behçet syndrome, where you have relapsing anterior uveitis, recurrent genital ulcers, and oral aphthous ulcers. These oral aphthous ulcers are very typical. They have a necrotic yellow center and a red rim around them. So these pathology skin tests that we hear about it a lot in Behçet syndrome may actually be negative, but these clinical signs that you see are very important. So if you ask patients the leading questions, whether you have these, they may come up with this. And the anterior uveitis in these patients are mostly bilateral and associated with hypopia in a seemingly white eye. The congestion may not be too much. One of the very important posterior segment finding that we miss in Behçet syndrome is a vascular occlusion. This may involve an artery or a vein. If you carefully try to isolate what is involved, you may actually be able to tell that whether it's the artery or the vein which is involved, and FFA is very important in these cases. So what you see as BRVO or macular BRVO may be actually an underlying Behçet syndrome many a times. Fuchs uveitis syndrome, often misdiagnosed, I would say. When you see Fuchs uveitis syndrome, it is very typical, like it is unilateral. The keratic precipitates are stellate and they are distributed all over the cornea. It's not only in the Arles triangle, that is the lower half of the cornea that is distributed, but all over the cornea. There will be no posterior synechiae. It's a low-grade inflammation. And because of this low-grade inflammation, patient usually develops a cataract. And one of the prominent features of this uveitis is Heterochromia Irides. That means the iris of 2 eyes may be different in their colors. So that if you can actually simultaneously examine the patient, many times even the subtle iris color changes you may be able to find. So this is only a clinical diagnosis that you can do. Fuchs uveitis syndrome is done clinically. You don't need to do any other test to detect Fuchs uveitis syndrome. Pars planitis, or what we call as intermediate uveitis, also is a very common and presentation that we see in our clinical in our clinics regularly. You have to very carefully look at the keratic at the cells in the vitreous phase. That's where you get the first clue. The patient typically always complains about floaters, and what we hear floaters, we always think that okay, we have to look for breaks and everything. But remember that even small opacities in the vitreous can cause a symptom such as floaters to the patient, and you have to look very carefully at the vitreous. Indentation at the pars plana can actually show you snow banking in these patients, and this may be actually localized in the lower inferior half. The intermediate uveitis sometimes can also be present as an anterior uveitis where there is a spillover effect, what we know as. And cystoid macular edema occurs in these percentages of cases, and even you can have periphlebitis where the vascular sheathing is around the veins, and there may be associated multiple sclerosis present in these patients with pars planitis. So TB uveitis, which is the very common presentation in our country, because TB in our country is endemic. It is a granulomatous uveitis associated with all features of anterior uveitis, granulomatous uveitis. In posterior segment, you can have a granuloma, as you can see here, which arises normally from the choroid. That's why you can see the retinal blood vessels over it. Miliary tuberculosis can be in form of multiple white retinal involvement along the blood vessel also. One of the pathognomonic feature of TB uveitis is that you may see sometimes healed chorioretinal lesions along the blood vessels, which is actually indicative of TB uveitis. So you can see this is the active TB uveitis involving the vessels causing vasculitis, and when it heals, it causes a pigmentation along the blood vessels. So this, sometimes you may see a patient where the TB uveitis has quietened down and then it starts appearing somewhere else. This clue clinically can actually tell you that it's TB uveitis or indicator. And then accordingly, you have to indicate tuberculosis. So this I'm presenting here because a lot of us have the confusion. So once we have excluded other causes of uveitis and we think it is tuberculosis, we should do a tuberculin skin test and a TB gold test. If either of them come out to be positive, you can ask for a chest X-ray or a CT scan, or you can even send the patient to be evaluated by an internist that you strongly think that the patient has TB uveitis, and to rule out systemic tuberculosis, and accordingly start treatment for him. If the internist or the investigation still come out to be negative and you still strongly suspect that it is latent tuberculosis or a presumed ocular tuberculosis, you can give him a trial of ATT for 6 to 9 months along with the internist. I have seen so many patients whom I suspected that they are tuberculosis, but the internist said that I don't find any indication of any systemic involvement. I have still told them that you go ahead with ATT, and those patients have actually responded well. If both tests are negative and patient has not been in contact with any tuberculosis patient, you may need further evaluation to rule out other causes of uveitis. Sarcoidosis, although we think that it does not exist, but it very commonly does exist. Granulomatous uveitis in anterior segment. You may have multifocal chorioretinal lesions and candle wax dipping, especially involving the veins. That is one of the most important clues. So just see in a case of uveitis which vessel is involved. That can give you a lot of clue regarding what is the underlying etiology. So vasculitis involving veins, you should strongly suspect sarcoidosis. So it is a diagnosis of exclusion where you may not find any cause. There are no definitive diagnostic blood, skin test or radiology that are specific for this disorder. Even though you may have high serum ACE and gallium scan, but they are not specific for sarcoidosis. So gold standard actually is a demonstration of a non-caseating granuloma from the tissue, which sometimes may be possible in a conjunctiva when you suspect conjunctiva sarcoidosis. But from retina, it is very difficult to isolate this. So it is a diagnosis of exclusion. Toxoplasma chorioretinitis, which we commonly known as headlight in the fog appearance. So this is where the vitreous has a lot of cells in it, and it is hazy because of this. That is vitritis, and you see the actual focal retinal lesion appearing as a bright yellow spot, as you can see in this photo here. And once they heals, it has a lot of pigmentation to it. So healed chorioretinal scar with a lot of pigmentation to it should actually tell you that it's the toxo which is healed, and it may get reactivated again anytime in future. So ICG, ICGM, any titers in toxoplasma are actually significant. VKH is one case where we commonly see in our clinical practice. It usually presents as bilateral multifocal choroiditis with serous detachment, but however, it may start in one eye and then appear after a few days in the other eye. So whenever you have multifocal choroiditis with serous detachments, you should suspect VKH. Typical angiography findings of VKH are multiple pinpoints with subretinal pooling of the eye, and which is very typical of this. And typical OCT picture where you see what we now call as bacillary detachment of the retina. You see a lot of cells intraretinally also, and this after proper diagnosis will help you in proper treatment. So important reasons for ordering investigation are that it will identify an underlying systemic disease. It may provide you a definitive etiology. It may confirm or reject a diagnosis, and therefore it will help in the management of the patient. So what to order? If one does enough investigation on any patient, that the chance that something will turn up abnormal may not be relevant. Attention should be paid on sensitivity and specificity of the particular investigation. Means you should know how sensitive or how specific that test is before ordering it. So like general investigation like complete blood count may tell you about raised eosinophil in parasitic involvement, or raised WBC in a bacterial involvement, or raised lymphocyte in viral or tuberculosis. Raised ESR or CRP may tell you about underlying autoimmune disease. Blood sugar may be raised in diabetes. Chest X-ray for sarcoidosis and tuberculosis. Specific investigations like HLA-B27. When you suspect ankylosing spondylitis, you order HLA-B27. You don't order HLA-B27 in all patients of uveitis. Like AC, angiotensin converting enzyme. Only when you suspect sarcoidosis or leprosy, you order those. HLA-A29 is a very specific investigation for birdshot chorioretinopathy. Similarly, ANCA in Wegener's granulomatosis. So IGRA is a quantiferon TB test is a very specific test. Similarly for syphilis as well as for CSF studies for non-Hodgkin's lymphoma or demyelination. So fundus fluorescent angiography may also help you in determining whether the cause is inflammatory or ischemic. ICG may tell you loss of it may indicate non-perfusion of choriocapillaries, though we normally don't do it. Electrophysiology, only birdshot chorioretinopathy, ERG is diminished. Otherwise, it is of no use. And OCT will help you in determining the complications like macular edema, epiretinal membrane, or whether there is any subretinal fluid present or not. And it will help you to monitor the patient. Similarly, sacroiliac joint exercise, bamboo spine, as you can see in ankylosing spondylitis, is a very specific investigation. So conjunctival biopsy, you may not very commonly do. You may do a PCR, which is at the forefront nowadays, where it may help you to tell you about infection associated with virus or tuberculosis also. And choroidal biopsy we rarely do when we suspect non-Hodgkin's lymphoma. So what I would like to summarize is that a short initial history of the patient after looking at him, then clinical examination. This will tell you, it will help you in classifying the disease. Based on that, you advise your laboratory and specific investigation. This will help you in diagnosis and therefore treatment. So in a non-granulomatous uveitis, if there are children, you have to suspect of GRA and TNU that already this chart is telling you. If it is HLA-B27 positive, then you suspect HLA-B27 uveitis and treat accordingly. If it is negative, then you try to rule out other causes and come to a conclusion. If there is hypopaeon, aphthay or genital ulceration, think of Behçet's. Otherwise, you have to treat it that way. Sometimes you may not still come to a conclusion about what's the diagnosis, but you still treat. But you try your best to get to the diagnosis. So similarly, in a granulomatous uveitis, you first try to rule out whether it's Fuchs uveitis. If it's not, then you order serum lysozyme, angiotensin converting enzyme, and tuberculin skin test. Accordingly, classify them as sarcoid or tuberculosis, which are the most probable diagnoses. You can still have other causes, but once you come to those diagnoses, you can treat them accordingly. Thank you.
Many thanks, Dr. Ashwin, for dealing with such a huge topic. Uveitis, it's a never-ending topic. I always tell my students, to manage a vitreous hemorrhage and retinal detachment, you have to be a good surgeon. But to manage uveitis, you have to be a good clinician. You have to have your antennae up all the time, and you have to be looking, for all the clinical signs and picking them up. Thank you. So with this, it brings us to the last talk of the session. That's by me. And, I'm going to deal with intravitreal injection and endophthalmitis. I'm going to start sharing my screen.
Ragini madam?
You should at least introduce Pritam.
Yeah, Ragini madam.
Ragini madam, may you introduce Pritam?
Yes, sir. So Dr. Pritam Samant is the professor in JJ Hospital. He's the president of the Bombay Ophthalmic Association. He is extremely dynamic, down-to-earth, practical. He established the department of the whole vitreoretinal department in JJ Hospital. He does say that Saili is the heart of the department today, but Saili is a student, but he is the soul of the department because, under his able leadership with Ashwin, Saili, and a big group of retina consultants and students today, he and all of us under the Chhatra Chhaya of Dr. Lanesar, Pritam has been able to grow and establish the whole department. And if you see today in Mumbai, the other colleges and all do not have such a huge setup and all the things available. So I think Pritam gets the credit for this. And I must say that when Pritam was in SN, there was a huge fight between Pritam's teacher and sir, and they were playing tug of war, trying to bring Pritam to JJ, and they trying to keep Pritam in SN. And I think Lane sir won for the betterment of the people in Mumbai and in Maharashtra. So Dr. Preetham Sawant.
Thank you, madam, for those kind words. So without delay, I'll start. My topic is intravitreal injection for endophthalmitis, something which I think every person who has a knife or a phaco or any instrument in his hand should know. Every ophthalmologist should know how to give an intravitreal injection. I'm going to my presentation today is going to deal with all these aspects. What is an ideal intravitreal injection? What is the choice of antibiotic? What is the role of intravitreal corticosteroids? The dosage, dilution, and administration, the clinical response and repeat intravitreal, the drug toxicity with intravitreals, what is drug-resistant endophthalmitis, and what are newer antibiotics. So the intravitreal drug administration was discovered as way back as 1944, where the intraocular injection of penicillin was given in Staph aureus endophthalmitis, and it was discovered that it does help to resolve endophthalmitis, but remember, when injected early, prior to irreversible destruction of the retina, it is most useful. So it has to be given post haste. What is an ideal antibiotic for intravitreal injection? One that is effective against the offending organism, one that is non-toxic to the tissues around, mainly the retina, one that has an appropriate half-life, which does its work and it goes and it dissolves, and which is easily available and cost-effective. What are the choice of antibiotics? So we are looking at a coverage for gram-positive and gram-negative organisms. Gram-positive organisms are covered by vancomycin. Vancomycin is the most potent, and cephalosporins. And for gram-negative organisms, aminoglycosides work very well, but because of their potential retinal toxicity, we fall back on cephalosporins again for gram-negative, that is ceftazidime. So vancomycin and ceftazidime is a cocktail we usually start with. Of course, if you have to modify the choice of your antibiotic based on three factors, and that is one, what organism you isolate. If you are going to start with the antibacterial and discover it's fungus, then you have to change to an antifungal. Similar again on the sensitivity pattern that your microbiologist gives you. Depending on that, you may have to stop the previous antibiotic and start with a new intravitreal antibiotic. And depending on the clinical response, if you're having a satisfactory clinical response or not, depending on that, you may have to change your antibiotic. What is the role of intravitreal corticosteroids? When it comes to bacterial endophthalmitis, it is a very good adjunct to intravitreal antibiotics. Essentially brings down inflammation and decreases the cicatrization of the retina that happens. It is important to reduce the exudation. The steroid that we usually prefer is dexamethasone because it has a very a short half-life, so it does its work and it has as least amount of toxicity. Now, what are the downside of corticosteroids? Of course, there can be steroid-induced toxicity, and its action itself, which is to blunt the immune response and bring down the inflammation, can accelerate the infective process if your antimicrobial agents have not yet kicked in. So remember, it is very important to use it in adjunct with antibiotics. One has to avoid it in fungal etiology for sure. Until now, there has been no definitive randomized study to study the role of intravitreal steroids in endophthalmitis. That is quite obvious. You can't have a randomized study in endoph. But practice-based medicine has taught us that in bacterial endophthalmitis, steroids as an adjunct to intravitreals are very helpful. So that brings us to what is the dosage of intravitreal injection. The most commonly used, most potent cocktail that we usually use is vancomycin 1 milligram, ceftazidime 2.25 milligrams, and dexamethasone 0.4 milligrams or 400 micrograms. How do you prepare the dilution technique? We essentially use tuberculin syringes, and you have to see what kind of a vial that you have. Now, normally vancomycin is available in 1 gram. You have ceftazidime, which is available either as, vancomycin is 500 milligrams, and you may have a ceftazidime, which is either 1 gram or 2 grams. So the dilution agent that you use is either balanced salt solution or normal saline or even sterile water for injection. And remember, you have to draw more than 0.1 ml in the final syringe, because your needle is going to take the dose is going to be lost in the hub of the syringe and in the needle. So one has to remember that before giving the injection. So finally, after dilution, what you should be having in your syringe is 0.1 ml of vancomycin, which contains 1 milligram, 0.1 ml of a cocktail of ceftazidime, which has 2.2 milligrams of ceftazidime and 400 micrograms of dexa. So cefta and dexa are combined together in one syringe, and in the other syringe, tuberculin syringe, you have vancomycin. So you're essentially injecting 0.2 ml in the eye. That is bound to raise the intraocular pressure. So one must follow it up with a paracentesis and ensure that the intraocular pressure is optimized. The injections should be ideally prepared within 24 hours of giving it, and ideally they should be very fresh. You have to prepare it and give it immediately. The administration technique is it has to be done given under topical anesthesia with a lid speculum space in place. You have to do all the essential sterile precautions of applying betadine on the ocular adnexa, preferably give a drape also, preferably do it in an OT. It can be combined with an AC tap or a vitreous tap, which you're going to send for microbiology. In a aphakic, you can use a limbal route. Otherwise, in a pseudophakic or a phakic patient, you are going to use the pars plana route, which is about 3 to 4 millimeters from the limbus. And for injection, you are going to use a 30 gauge needle. It has to be injected in the mid-vitreous cavity, ideally with the bevel of the needle pointing away from the macula, because you don't want a huge bolus of the drug going on the macula because of you're worried about macular toxicity. Inject slowly, drop by drop, and in combined therapy, the drug should be preferably injected separately. Once you have injected intravitreal injection, what do you look for? You look for the clinical response, and ideally you should get a clinical response within 24 to 48 hours. What you have to look for is decrease in the corneal edema, decrease in the conjunctival congestion, decrease in the anterior chamber cells, flare, hypopyon coming down, and your vitreous exudates clearing up, allowing you to see the retina more clearly, and most important, improvement in vision. Now, ideally, this is the kind of response you should see. You can see the one on the left, and after an intravitreal injection, you can see how the hypopyon is down, the cornea is cleared up. Although there is some fibrin in the pupillary area, this is a good response that you're seeing after intravitreal injection. When will you repeat an intravitreal injection? So if there is no clinical response in 48 hours, then one must repeat an intravitreal injection. Or within these 48 hours, if your microbiology report is telling you that no, you need to change the antibiotic because of the sensitivity pattern, then you may have to change the antibiotic and repeat the intravitreal injection. Usually a rule of thumb is that if you are having no response with 2 consecutive intravitreal injections, then that means you have a large load of the organism in the vitreous cavity and you have to go for vitrectomy. Then you should not delay the inevitable vitrectomy. That brings us to the drug toxicity of intravitreal injections, and that there has been enough evidence in literature to suggest that some of the aminoglycosides cause macular toxicity. They can cause outer retinal toxicity, full thickness retinal necrosis, macular infarction. This is typically a picture or an FFA done in a patient of macular infarction. You can see how large the foveal avasculosa are enlarged over here because of macular infarction following gentamicin injection. So that's why the aminoglycosides are more or less given up, and nowadays we prefer to give cephalosporins instead of that. Again, one must remember dexamethasone can also cause toxicity, so one must not use more than 400 micrograms of intravitreal dexamethasone. That brings us to the topic of fungal endophthalmitis. In fungal endophthalmitis, you have to use antifungals. One must not use steroids. Now, the antifungals of choice nowadays, voriconazole is a very potent antifungal that we have in our armamentarium, and that is usually the preferred antifungal nowadays. The dose of voriconazole being 50 micrograms in 0.1 ml. You can alternatively also use amphotericin D, which is 5 micrograms in 0.1 ml. One must remember the aspect of resistant microbes, especially when you're dealing with gram-negative endophthalmitis like Pseudomonas. We had a couple of years ago a series of cases of Pseudomonas endophthalmitis from one hospital, during which our backs were totally against the wall, and we didn't know because we were using vancomycin, ceftazidime, dexa, and it was not working. So those cases also underwent surgery, and we finally, when we looked at the antibiotic sensitivity pattern of that Pseudomonas, our jaws dropped, because as you can see here, it was resistant to everything that was there in the book, and the only thing it was sensitive to was this drug called colistin. frankly, I had not even heard of this antibiotic. But when I checked with some of my nephrologist colleagues, they said that we routinely use this in drug-resistant pseudomonas. So we tried, we injected colistin in these cases, and to our amazement, we were able to save at least 3 to 4 of the 8 eyes after injecting colistin. In fact, we published our results in IGO in February 2012, and following that, we've been using colistin in drug-resistant pseudomonas. There have been a lot of other colleagues of mine who've been using it with good results. That is our article which we published in IGO. So colistin, like I said, it's a very potent antibiotic which we use in adjunct with other antimicrobials. So with that, I would like to conclude this talk. Thank you so much.
Thank you, Dr. Preetham. Your other teacher, Dr. B.K. Nayak sir, has joined. So Dr. Lani sir, Dr. Nayak sir, the president of All India Ophthalmic Society, Dr. Natarajan, the past president of All India Ophthalmic Society, Dr. Ranjit Manyar sir, Dr. Vijay Bhatt, Karobi ma'am is here, and the mentors for all of us have joined this session. Thank you, dear all. So Preetham, you can
Ma'am, so if we can have some.
Dr. Nikhil Gokhale has joined.
Dr. Karobi and Dr. Ramchandrani were moderating the session. So if we can have some comments from them. We have covered 4 topics in this last 1 hour. Dr. Karobi ma'am, Dr. Suresh sir.
Preetham, all 4 of you have delivered these lectures in a very nice, tight, crisp manner, because the amount of time for each of these large topics was a little less, but still you'll have done justice to it. A few comments on certain topics. That is, I know there was lack of time, but in the macular hole surgeries, recently they have tried using amniotic membranes for sort of putting it under the retina after mobilizing it, and that has shown by Stanislaus Rizzo that it has good effects of closing the macular holes, where the macular hole closure is about almost 94 to 97% with this technique. One important aspect is also about the positioning of the patient, because if the hole closure is good, a good positioning for just 3 days suffices to close the macular hole, and you really don't have to subject the patient to long, like sort of many days of positioning for closure of macular holes. And with the improved techniques now, we find that the closure of macular holes is much better than what it was. There are some other instruments called, which have these olive-tipped ends, which can be used to massage large macular holes for better closure effects. Suresh, any other comments on the macular hole closures that we just witnessed?
No, Karobi, you have covered everything, more than everything. I mean, macular hole is a topic which has been discussed ad nauseum. Everybody is just talking. It looks like all retina surgeons are only after macular holes now. Detachments are eradicated.
I know.
Yeah.
Yeah.
No, Suresh, you have to come back to JJ, the huge list of detachments and everything possible.
No, I'm
under
joking,
the
Ragini.
No.
I'm joking,
Not
Ragini.
like, 1 minute. It is not like that. Ramchandani, Suresh, and
Yes, sir.
the detachment is now for the anterior segment surgeon, and hole is for the posterior segment surgeon.
It looks like that, sir. It looks like that. You know, everybody just discusses macular holes. It looks like everybody has conquered the retinal detachment, traction detachment, but you know, just macular holes, one after the other. How to do this? How to do that? Yes.
Dr. Natarajan sir, any words from your end? Your tips for macular hole?
Hello, good morning.
Hi, good
So I was
morning.
wondering whether I'm
Happy
doing
birthday,
no, I nowadays I'm doing macular buckle for macular hole detachments, and I think macular hole I use the inverse flap technique, and then secondary if it reopens I'm using that amniotic membrane graft, but sometimes I'm having difficulty to keep that graft in position. And I think, I mean, as Ramsha Suresh said that everybody thinks retina is macular hole, but I think, anyway, I do it as a regular surgery, and I tell the patient, the problem is about vision. It's not only closing. So I tell the patient, well, if you get vision, thank God. If you don't get also, thank God, and then operate.
Dr. Natarajan, could you tell us about the macular buckle, please, that you're using?
I forget from where I buy. I'm actually like what Shankarathila is using. So there's a technique described by Barbara, but they use a different macular hole buckle. The one we are using is what Shankarathila is using. So I use they have a band which goes, you also hook the inferior oblique and then make sure that the macular buckle goes. But I'm trying to thread that, what do you call that, light cable into that. Somehow, in spite of all that, I have the difficulty to make sure whether it is exactly in the macular hole. Sometimes I'm not able to make 100% sure whether it is supporting the macular hole. But whatever I've done, fortunately, that is placed. So I think if you pass through the superior oblique and inferior oblique, the band, and then tighten it mildly, and it works. And I think from Barbara, I do is a two-step. One is do the macular buckle. If it opens again, then do a vitrectomy with Ilm Peeling and use the, if at all, sometimes I used Denziron and then I remove it. The problem with Denziron is the pressure goes up.
Thank you, sir. So, Dr. Karobi, any more questions, or maybe we can conclude?
No,
then?
I think we can conclude.
Okay. So, I would like to thank all the four presenters, Dr. Saili, Dr. Ashish Jain, Dr. Ashwin, and with that, we would like to conclude this session on retina. And over to you, Ragini Madam, for the next session on cat.
So Preetham, I think since I'll just start the session and you continue. So it is Teachers' Day today, and an auspicious beginning to this Gurukul series. And what better than to have the mentors of BOA, the people who built BOA brick by brick, who laid the foundation and made it for the last few years an organization which is to contend with in the whole of India, being present here today to, as usual, to guide us, to bless us. So we have with us Padma Shri Dr. Lahane sir, the President of All India Ophthalmic Society, Dr. Nayak sir, Padma Shri Dr. Natarajan sir, who's the past President of AIOS, Dr. Ranjit Manyar sir, Dr. Vijay Bhatt, Dr. Karobi ma'am, Dr. Nikhil Gokhale, and everybody who is present here today. And we are the alumnus of JJ Hospital. So, Preetham, would you like to take this forward? Our Lahane sir, would you like to conduct this?
Thank you, Ragini. It was a retina session, was very nice, and I think the JJ is the only department in Maharashtra who is doing the full-fledged retina surgery. And thanks to Preetham, who joined us in 2004, and thanks to Pico Dynamics, who permitted him to join the JJ hospital. And because of that, I think this was possible. And this was the, I think, Hinduja and the JJ benefited because of him. So today, I welcome Dr. Pico Dynamics, Dr. Ranjit Manyar, Dr. Natarajan, Dr. Vijay Bhatt, Dr. Nikhil, and all my alumni from the JJ hospital. And I think after the retina, now we are going to go to the cataract. And as you know, the cataract is a very huge topic. So in that we have kept, I think, a few topics. So I will be going first, and then Ragini.
So before that, sir, we have this small little gathering of 10 minutes so that everybody can give blessings and we can take blessings from all our teachers. So we can start with Dr. Vijay, Nikhil Gokhale, Vijay Bhatt, in that order, and like how it goes, and then last the chief person. So
yeah, I think it's a wonderful idea, Raginiban and Professor Lahane sir, to a good conception by Preetham and all the team. I mean, it's congratulations on this wonderful thing which you have started today. And who better than Lahane sir and Raginiban, who have been doing an astounding work in cataract surgery and all over Maharashtra. And I really congratulate the whole team on this wonderful thing.
Yes, and something about the BOA, our organization, the parent organization due to which we are all here today. You are the mentor, you are the guide.
No, BOA, I think, has been going, as you mentioned, from step to step, and really at a certain stage right now where I think we have been in the forefront in the ophthalmology part all over the India. And thanks to all the mentors all over the years, right from, if I remember, from Kirit Modi sir to Keki sir, and at present the whole team. Thanks to all of us, and thanks to all of them that we are in a great position, not only in the teaching part, but also in all other aspects.
Thank you, sir. Dr. Nikhil Gokhale, sir.
Yeah, thanks, Ragini, for giving the opportunity. Actually, I think I'm still a student, and probably all of us, all our life, continue to educate ourselves. You know, we can never say that we have learned everything. So I think each of us in each of these webinars does learn a little bit more extra, and I think this is a very good initiative by BOA to have academic session, and I think it basically is to promote institutional feeling also, which I think should be there amongst all the doctors in Bombay. Not only that BOA feeling is there, which is of course extremely strong, but I think college wise and institution wise, respect for your teachers is something that we all have to learn, because we are what our teachers have taught us. And I think today is a very great day to start this program on Teachers Day, because it's the right opportunity for us to really kickstart a very new program today. Thank you.
Thank you so much, Nikhil bhai. You have very rightly said everything. Dr. Ranjit Maniar sir, Bapu.
You know, on a universal basis, we would recite today Gurur Brahma, Gurur Vishnu, Guru Devo Maheshwara. And you want to continue? That's
Guru
Sakshat Parabrahma.
Tasmai Shri Gurumai Namaha. Thank you. So that is on the universal front. You would remember today and propitiate all your gurus who have taught you ophthalmology, your colleagues who continue to inspire and teach you. But most important, your biggest gurus, Ragini, are your patients.
Yes.
Are your patients.
Yes.
They keep teaching you and you keep learning new things, not just from your colleagues, peers, and teachers, but even from your patients. Where BOA is concerned, it was such a nascent, small organization of around maybe 70, 80, or 100 people who used to meet only on Wednesday evening at Virtually Hospital or somewhere in the night and have clinical case presentations. And from there to take it to an international scale, wow, it's been a fantastic journey. I have been a witness to it. I have been a participant there and enjoyed every moment. And in fact, I am now basking in the glory of these young guys who are doing so well. And the first lot of speakers that you had, they were so good. All of them, Dr. Jain, Dr. Bafna, Dr. Staili, Preetham, they were poised, the slides were good, the presentation was spot on. And as Karubi mentioned, the huge topics were covered in a very small time in such a beautiful, succinct way. It was wonderful to watch, and it is a sense of great pride that JJ Hospital has taken the lead here. CJ is over, I think, correct me if I'm wrong, but it should be around 140 years old by now.
Yes, sir. It's more than 1908 it was commissioned, sir.
110. So I think CJ has taken the lead along with KM, Nair, JJ, everybody, but it is fitting that the Gurukul starts with CJ Ophthalmic under the guidance of Tatya Rao and you. It's wonderful. Yeah, I'm really enjoying this. Yeah, really enjoying.
Thank you, sir.
Thank you.
Sir.
God bless you all.
Thank you, sir. Pai Lagu. Thank you so much, sir. Padma Shri Dr. Natarajan, sir.
Thank you, Ragini. And I just quickly share my screen for only 1 minute. So I just wanted to I always do this every time. So this was my talk. So my guru is Swami Vivekananda, arise awake and stop not till the goal is reached. So I just want to say, so I'm born in Madurai, like Dr. Lahane came. So I always have Mata Pita, Guru, Mitra, Deva all the time. And my father gave me education, my mother gave me love. So I preserved my fees. I only paid 200 rupees, 232 rupees as that's my fees, which I paid for medical college. So I owe everything to the government, and here is the government of Tamil Nadu. So I just want to say this is my time with Dr. Badrinath, and that's my second mentor, Dr. Raja Jovanovic, and Dr. Madan Gopal, Dr. Madan Mohan. I learned microsurgery in 1983 in the end. That's why I just want to talk about today, the Happy Teachers Day, and also my great forefather, Vavu Chidambaram, who's a freedom fighter who got the first ship for India against the British, V.O. Chidambaram. So that's my guru, and he follows the words of Sankaracharya. And Adi Sankaracharya said, not by penance, not by visiting holy river, not by reading scriptures, not by chanting mantras, but by only performing selfless service, humanity, one can cross the ocean of life. And we have Dr. Tatya Lahane as an example, doing the number of cataract surgery in Maharashtra. So this is my last slide to mention about my guru. The mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, and the great teacher inspires. And I think every day I bow down, I bow to him, and my greatest thing was 100th year of Mahakavi Bharati, where he bows down to me. So I salute all the teachers here, and I also salute the students here who have given me the opportunity to teach. Thank you.
Thank you, Dr. Natarajan, sir. Our mentor, guru, who worked hard to bring BOA to this level, and now the president of AIOS, Dr. Nayak, sir, Bapu. Dr. Nayak, sir.
Yes. Good morning, everyone. And thank you,
morning,
Dr. Ragini, for giving me this opportunity and remembering me. And first of all, I just want to say, Tatya, that he should not be thankful to me. I am thankful to him because he allowed Preetham to come and join. And now he joined, he allowed that, okay, Preetham will also work in Hinduja. So that was basically, and that is no doubt about it, that both of us, both institutions have gained from this. So there is no doubt about it. That is one point. Second.
No, I just forgot to tell. So I'm happy the guru for Preetham.
Big presentation was there. You should have mentioned that. Okay, so.
Yeah, I know. And also for Saili, Dr. Badrinath.
Okay, so now, apart from this.
Absolutely.
Hello.
Yes, sir.
Yes,
sir, we can hear you.
And one very genuine confession that I always wanted to be a teacher. Teacher means in a teaching institution where your name in front of you is either professor or lecturer, something like that, it should be associated. But that luck was not with me. And I tried hard, but I could not get in AIMS RP Center. So that is anyway old story, and then everyone has to move on from wherever.
Sir, can I interrupt, sir? Dr. Lahane sir is still here. You and Lahane sir are one. So with Lahane sir's help, we will make you an alumnus of JJ and Professor Barun Naik.
Unfortunately, JJ, I have not even studied in JJ. Only thing I remember, JJ Hospital, before coming to Mumbai, that I had come, that time a different sort of examination for DNB used to take place after passing your post-graduation degree. So I came for Viva practical in JJ Hospital. Year I don't remember, I think 1982 or something like that it was. So that is my initial memory and interaction with JJ Hospital. And that time, doctor, he was the head, what's his name? I just forgot. Padmavar. Dr. Padmavar was the head of department, and after that exam, he became my friend. And when he came to, because that time in RP Center as senior resident, so when he came to RP Center for one course, then I was giving lecture to him. But then he was suffering from peptic ulcer, so he never could eat all those normal food with spicy. So he used to bring his food and come to my room and eat food over there during lunch break. So anyway, that is all those things are old story. And just past remembrance. About the BOA, I very well remember that when I joined BOA, the first meeting which I attended was in one of the hotel in Juhu. And there I became member. And after that, really BOA, I have to thank BOA that BOA has given me all opportunity to progress and to prosper. So once again, I thank everyone. And now I am so happy that BOA has reached to this stage where everyone is remembering BOA, not only in Bombay or Maharashtra, but outside Maharashtra also, all over the India. So that is a great achievement. Thank you very much once again, everyone.
Thank you so much, sir. So there was a tie because since BK Naik sir is the president, he has to be actually the last speaker. But Lane sir is a mentor for this Gurukul and a Padma Shri. So I consider that both of you together are the last speeches. Dr. Lane, sir.
Good morning, everybody. I wish them everybody as today is the Teachers' Day, and happy Teachers' Day to each and everybody. And I think from today onward, we have started this Gurukul, very good concept. And I'm very much thankful to BK who joined, the Natti, then the Vijay, Nikhil, Ranjit, Karobi, and everybody, Suresh, who has joined today. So we are the teacher. Like the Ranjit said that we are taught by patient also. So we must treat the patient with patience, and we must also teach our student. And so unless and until we teach, they are not going to learn and take good things in the future. So I wish everybody the best wishes, good wishes, and success in their life. And thank you very, very for joining today in this Gurukul concept of Bombay Ophthalmic Association. Thank you.
Thank you, Dr. Lane, sir. Dr. Keki, sir, Cyrus is turning 50 today, so he said he's busy. And Kuresh, sir, had a Rotary meeting. And I'm sorry for the last minute calls to everybody, but this couldn't have taken off on Teachers' Day without you all. And all you mentors, we are and will remain your students. Whatever BOA is because of all of you. And we will continue to work under your guidance so that BOA can prosper. And BOA is unlike any other organization because here there is one set and one team of teachers who remain and who guide us. There is no other thing which happens, and that's why BOA has grown so much. So with pranam to all my teachers and mentors of the BOA present here today, Preetham, and all of us, we wish you thank you and say pranam to you once again.
Ragini, a big thank on behalf of all the teachers here for having us here. Last minute is not a problem because BOA, we are all there for every minute for each other. And thanks to Tatya for the excellent leadership and Varun for leading All India now. And
Thank
we
you,
have
sir.
the Dronacharya.
Pranams to everybody. Happy birthday to you, Nati.
Yeah.
Happy
birthday.
Let's
Happy birthday.
Happy birthday.
Belated one day before. Belated happy birthday. Okay.
Thank you, sir. Thank you, everybody.
Thank you. Thank you.
Your head is shining as a teacher today.
Thank you, sir. Lani, sir, I'm doing SICS, so can I go first or will you go first? It doesn't matter.
You can go
You can go first.
Yeah, no, as you feel.
No, whatever you say, sir.
You go first, no problem. I will be there. Dr. Ragini.
Yes, sir.
I will present the 10 steps for the SICS. Dr. Ragini has done 76,000 surgeries and she has conducted 579 and operated in the 168 camps all over Maharashtra. And she is the real, I think, the ideal.
So I'm trying to share.
रागिनी तुला हे बंद करावं लागेल. बंद कर, इकडून राईटला वर जाऊन बंद कर.
Yes, sir.
हा, आता आलं तुझं. ओके.
So Sumit sent me a presentation, and he sent me a presentation yesterday also, but some videos of that are not opening. Thank you, everybody. Thank you, Dr. Lane, sir. 10 steps to a perfect SICS.
दोन वेळा कर, नेक्स्ट कर खाली याच्यात स्पेस बारला लाव, स्पेस बारला दाब, मधला.
मॅडम लेफ्टला वॉटरमार्क असेल, राईट आणि लेफ्ट एरोचं, लेफ्ट डाऊन
मार्क
वॉटरमार्क सारखं किंवा एरो.
Yes. So what is the scenario today? Because cataract is a catarefractive surgery. Patients all want spectacle free vision, and what they want is a simulation of natural vision. With the advent of flax and newer generation IOLs, it has been possible also. So I will be talking on SICS in relation to the expectation of patient's vision. These are the steps of SICS: a sclerocorneal tunnel, capsular X's, hydro procedures, nucleus rotation to ensure a free movement and complete comfortable delivery, because the nucleus has to be brought out of the bag and delivered, cortex aspiration and IOL implantation. So the first step after the brittle suture is the conjunctival flap. It's very, very important, though it appears to be a very simple and an easy step. It covers the incision. There is no irritation of the tunnel to the patient, and it's a very, very important step in the SICS surgery. So as you can see over here, the eyeball is rotated down so that you can see, and a fornix-based conjunctival flap is made. You don't make it at 12 o'clock, you make it slightly at 2 o'clock or 10 o'clock, depending on whether you are left-handed or right-handed, and you make it and in such a way so that it can be reposited back like a hood, and there is no need to do anything. It sticks on its own. After that is the sclerocorneal tunnel, as you can see over here. So this is the groove which is made about 1.5 millimeters behind the limbus. It's a modified frown incision, as you can see over here. And it is very easy to make. And when we are teaching, we always say that make it like an inverted board shape. Circular incisions are a little difficult because they are freehand, but this is very easy to make, as you can see. So this is the first groove, and then the correct instruments are very, very important. You start with a pocket with a 2.6 crescent blade, as you can see, in half thickness of the sclera, which is the connective tissue. The tunnel is dissected, and as you can see over here, the tunnel is dissected and the pockets are made. You dissect not only the sclera, but you enter up to some millimeter into the cornea because it's a sclerocorneal tunnel. These are the side ports which are being made for the AC maintainer and for the other instruments. They are made with 1.1 MBR blade. The correct blades are very important. This is the opening of the tunnel with a keratome, as you can see. And if you are doing it correctly, then there will be a dimple. You cut as you go in and not as you come out. And it is very important, as you can see over here, that there is a proper pocket. The internal incision is smaller than larger than the external incision, so that the nucleus can be safely delivered. After the tunnel is made, the rhexis is important. The beauty of SICS is that it can be done without a capsular rhexis. This is me, a left-handed surgeon, as you can see. A fully dilated pupil, a good glow, a larger magnification is important. As you can see, you can do it with a capsulotomy needle, which is a 26 number bent needle, or a Utratas forceps can be used, and the rhexis is made. A rhexis is very important for phacoemulsification, but the beauty of SICS is that it can be done even without the rhexis. This is a rhexis in a small pupil. And I'll be showing you one more video of a dye-assisted rhexis, which can be easily seen. So in a mature cataract, if one does a can opener or an envelope, it is okay. But dye can be used to stain the capsule, and which can be done, as you can see here, the capsular rhexis is being done with a Utratas forceps. And so it can be done with a Utratas forceps or a capsulotomy needle. Both can work. The aim is to do a capsulorhexis. Hydro procedures follow the capsulorhexis. So this is a 25 gauge needle which has been fashioned into a cannula which is filled with BSS. Multiple points of hydrodissection can be made. The golden ring, the superior prolapse of the nucleus are the end points of the hydro procedures, and this helps the nucleus to be separated from the cortex and the epi and the endonucleus so that it can be easily delivered. Hydro procedure is a very important step in SICS, without which it would be very difficult to remove the nucleus. As you can see, this is the golden ring and the slight solute of the nucleus, which is then prolapsed into the anterior chamber, as you can see. So hydro procedures are very, very important. Simple instrumentation, that is a 25 gauge needle converted into a cannula on a syringe filled with BSS, is all that is required. This is a small pupil in which hydrodissection can still be done very carefully under the pupil. As you can see that the nucleus is lifted because of fluid. One has to be very, very careful. Small points, multiple points of small amount of fluid. Otherwise, there can be a blowout and there can be a PC tear, especially in posterior polar cataracts. And then the nucleus is rotated and brought out into the anterior chamber. So this is one step or a part of the nucleus delivery, where this is called as luxation, where the nucleus is brought out in the anterior chamber before it can be delivered after the hydro procedure. Nucleus management, there are various techniques for nucleus management. The techniques are used to deliver a free nucleus. That is very important. The key word is a free nucleus. What we are using is the visco-expression technique. I do the visco-expression technique and Dr. Lahane sir does the Blumenthal technique because we are a teaching institution. Lots of techniques are in vogue, like the snare technique and lots of the sandwich technique, the phaco-magnification technique, anything that works in your hand, which keeps the cornea, the iris and the patient safe and which works well in your hand is the technique that you should be following. So as you can see over here, this is the Blumenthal's technique. Sir is doing it. This is the AC maintainer and the glide. The glide is nothing but a polypropylene sheet which helps, as the name suggests, the nucleus to glide over, and the epinucleus can also be removed, which is, as you can see over here, the glide and the eyeball is held with the limbs, and with the pressure and the counter pressure, the nucleus is delivered. The Blumenthal techniques remains the most physiological technique with the AC maintainer, and the nucleus can be delivered. The second technique is the visco-expression technique. After that, you can see the cortex aspiration. Here you can see a posterior polar cataract. And this is just a demonstration video of phacoemulsification, but this is the AC maintainer and the aspiration. This is the single port modified Dr. Lahane's cannula, and which can be used to do a complete 360 degrees of cortex aspiration. Only thing is here, the tunnel is not small, it's a sclerocorneal tunnel, and all the main incision and the side ports can be used to do 360 degrees of cortical cleanup. The undersurface of the posterior capsule can also be polished. So cortical cleaning remains a very important part of the surgery because you want very good results and the patient does not want a posterior capsular opacification. By interchanging the ports of the anterior chamber maintainer and the aspiration cannula, a complete 360 degree of cortical wash can be done. So this is a complete video, as you can see, from starting to the film. This is the hydrodissection, and as you can see over here, this is the visco-expression technique, because initially we saw the Blumenthal's technique. I'm a left-handed surgeon. So the nucleus is brought out of the bag, and with nothing but a normal viscoelastic syringe but the superior bridle suture is very, very important. With the syringe and the viscoelastic, it can be removed. And as you can see over here, the AC maintainer is in one of the side ports. You can use the main port or the second side port to do a complete 360-degree of cortex removal. The undersurface of the posterior capsule can, and now you are using the second port. So the 12 o'clock cortex can be removed by using the side port. And that is the beauty of the AC maintainer and the aspiration cannula. As you can see over here, there are certain small fibrinous strands which are there on the posterior capsule, which are also polished. The AC maintainer keeps the bag inflated, and hence it's very safe. Here, the IOL is implanted under the ringer lactate only, but viscoelastic can be put and it can be inserted. As you can see, since the IOL is in the bag, it is nicely centered. This is very, very important. The end of surgery, the side ports have to be hydrated. They should not be more than 1.1 millimeter. As you can see, a small incision, this is around 4.5 millimeters, is possible because the lens was not very hard. And at the end of surgery, the conjunctiva is placed back. A tight wound at the end of surgery is very, very important for the safety of the patient, as you can see. The take-home message is to observe, practice, and learn the correct technique. I was fortunate to have Dr. Lahane sir as my teacher, and he became left-handed trying to teach me surgery, and he can now operate with both hands. It is important to know your SICS well. I always believe that half of the steps, that is making a tunnel, making a rhexis, the hydromaneuvers, are all cortex through a small incision, IOL through a small incision, can all be learned in SICS. And then what you have to learn is phaco. So I learned SICS before learning phaco emulsification. So if you know your SICS well, you already know half your phaco. It's very important. Thank you so much for the opportunity. Thank you, BOA, for giving me such an opportunity to grow. Thank you, Preetham and Swapnesh. And last but not the least, thank you, Dr. Lahane sir, my teacher, because of whom I learned everything that I know today. Thank you so much.
Thank you, madam. Lahane sir, should we invite comments from our moderator? Dr. Nankani sir is there. Dr. Gul Nankani sir is there.
Dr. Gul, hi.
Hi, Ragini. Good morning, sir. Good morning, everyone.
Good morning.
At the outset, what a wonderful effort by Swapnesh and Preetham to have this Gurukul on this auspicious day of the Teachers' Day. And nobody else better than Dr. Lahane and Dr. Ragini, who have been mentors, teachers, and also a unique combination of very high volume of surgeons to teach so many people on the BOA forum who want to learn today about cataract surgery. So Ragini, a wonderful presentation on the SICS. I think you covered both the ways using visco and without the use of visco with the blue menthol technique. But between the two, which one do you prefer? Do you prefer using viscose or implantation of the IOL and also doing the rhexis, or do you prefer with the AC maintainer?
So I do it with because when I'm doing cortex aspiration, there is no viscoelastic. So I'm comfortable because I know that I don't I don't cause too much pressure. The tunnel doesn't open or collapse. There is good AC form. So I prefer to do it under ringer lactate because if there is a problem, if the AC is shallow, if the patient is squeezing, then I put viscoelastic and then put in. So both ways are possible. For me, this is easier because I don't have to then go back at the end of surgery and remove the viscoelastic, because I believe that the whole of the viscoelastic should be removed at the end of surgery because it's an external agent that you are using. You don't want to let it remain in the eye or to block the trabecular meshwork the next day. So I prefer to put it with the AC maintainer and the ringer lactate. But it can be done both ways, and the ease, the comfort would be more with a viscoelastic, and I prefer it. And between Blumenthal's technique and visco expression technique, I'm comfortable with visco expression technique because I'm scared of a no visco technique. But till today, the most physiological technique with terms to the no hypotony, especially in myopes and all, Blumenthal technique remains the most physiological technique for the SICS surgery.
I think what she says, it sounds very easy, but for the beginners, probably the way to start would be with viscoelastics. And then as we graduate and as we are more confident with the surgical procedures, one should try and get onto the visco-less surgery with the blue menthol technique. Like Ragini said, that leaving behind visco can always create a problem in the post-operative period, and a wonderful done surgery can end up in a mess. So to start with viscoelastics and then get on to graduating over to the visco-less surgery is the way to go. And I think wonderfully demonstrated.
Absolutely true. Absolutely true that, you know, you should not try, be adventurous, and visco, lots of visco to protect the endothelium when you are learning is the key. Absolutely true.
Excellent. Can I invite Professor Dr. Lahane, who's had more than 100,000 surgeries to his name, and no one better than him today to take us some tips on the phaco surgery, especially for the beginner.
Thank you very much. I think where is my presentation has gone.
Sir, till you load, I think, sir, you use Glide for SICS, na?
I use Glide.
Could you give some valuable tips quickly for that?
See, I think my presentation, some problem is there. I will see. Okay. So now.
So can I share the presentation from my side?
No. I have got the presentation. Don't worry. Okay. Now can you see my presentation?
It's a blank screen, sir.
It's
come.
Yeah. You can see the screen, na?
Right.
Is it visible? Is it visible now?
Yes, yes.
Okay. Thank you very much. Thank you, Gul. Now I am going to speak on the 10th step to perfect phacoemulsification. Now see, there is no financial interest in any topic whenever, and now we should be like him. So that is the Guru. Now the basic steps whenever you are considering the phaco, as it is a Gurukul first presentation, we have decided to go for the basic. The corneal tunnel or limbal or scleral incision, ischioelastic, then the capsular axis, hydrodissection and delineation, then the phacoemulsification, cortical removal, then the IOL implantation and wound hydration. These are the steps that we do in the phacoemulsification. Now practical tips are: train your non-dominant hand and the leg. See, minimum hand is required. See, you'll have to train your non-dominant hand because you'll have to hold the chopper in your left hand. Then the another trick is selection of the case in the beginning is very, very important. If you select very soft cataract, then you may tear the PC. So select the grade 2 or grade 3 cataract. The dilatation is important. If it is not dilated, I think the beginner should not do the phaco. And another thing is a cooperative patient. This is also important when you are a beginner. Now this is, you must see the patient on the slit lamp so that you will come to know that this nucleus is of grade 2 or 3. The other is a wet lab practice. See, you are going to operate on the human eye, which is the most sensitive structure of the human being, and 82% of the knowledge is gathered by the eye, and so minimum 60 hours of the practical practice in the wet lab before touching the eye. So this is what is the wet lab. And the other is this: whenever you are going to learn the phaco, learn a machine before you learn the phaco. So you'll have to learn the machine, and machine is very, very important whenever you are learning the machine. So this you will have to learn. Then adequate tunnel and rhexis. See here, the tunnel is very important. If the tunnel is larger, you will get the leak. Tunnel is smaller, the tip can't go in. So tunnel size and phaco tip size should be similar, and like that the tunnel blade. The rhexis, initially you can go for the 5 to 6 millimeter rhexis, and you can mark it on the cornea so that the rhexis will be easy. Then the phacotunnel and rhexis, I will just show you in the video. See this. Here you can see now how I'm going in. So the blade was not straight. It has taken on one side, then entered in. And see now, this is I'm opening by the 2.8 blade, and see now the rhexis. The rhexis I am doing by the needle, that is bent needle. And this you can see this. You should do it parallel to the pupil. Once you do it to the parallel to the pupil, definitely you can have a good rhexis and center rhexis. So pupil is important. Whenever pupil is, you can say, not normal, that time you can consider any other thing, but pupil is a guide. The complications, yes, complications can happen with each and every person. He may be senior or he may be junior. So don't afraid up, but treat it properly and try to avoid the complications. Now, whenever you are doing anything, you will have to see the machine. Now see here, I am operating, but the tip is moving. So whenever you are doing any phacoemulsification, you must see your instrument, and here you will see the tip was loose. So such type of anything in the machine can trouble us. Now nucleus, start with the divide and conquer. Always start with the divide and conquer, then progress to the stop and chop. So I think first divide, conquer, then stop and chop, and then direct chop. So now don't go from direct to behind. Go from the divide and conquer to the direct. So that is what should be the sequence. Now nucleus management, divide and conquer, stop and chop, direct chop. So you can use any of this technique for the nucleus. Now here the deep groove is very, very important. So you must see the glow. Till that time the groove should be deep. 80 to 90% of the depth in the groove, the right angle to each other, and then you can start the division of the nucleus. Each segment then emulsified. So you have to make two halves, and then each segment is emulsified. What is the disadvantage in this? Increase phaco time and energy here in this technique. Now trench, divide and conquer. Trench should be small, central, vertical. More nuclear density. If it is more, then the longer. Like to go to the periphery. Then the crack starts at the posterior pole and then extends to the 6 and 12 o'clock position. Now see here, this is I have chosen this. This is done by Dr. Sumit, who has done my presentation, and from 2 years now I am not doing any presentation. He is doing the presentation. If it is good, the credit to him. If it is not good, discredit to him. Now see, this is what I am doing. See here, I want everybody to see the trend. See here. So I am doing it very gradually. See on both sides, and it is slightly larger than the one tip, and you can see now the glow is seen. See, can you see the glow? So unless and until you see the red glow, you must do the and then now you see you are separating here two halves. See here, whenever separating, come up to the center so that the rubbery fibers are separated, which are there behind. See now on other side. So instead of making another 4 pieces, important now see here, the centrally it is more attached as there is no space more. So you will have to separate it from the center. And once you have made 2 halves of the nucleus, then your not half, that is the full thing is done. Then the crater, divide and conquer here, deep central sculpting to produce a large crater, leaving a dense peripheral rim. It is very important. Don't go to the periphery. Then the harder the nucleus, the smaller the waste sections, the Pico Dynamics, continuous irrigation, and the high Pico power 40 to 50, low vacuum. Pico 2, low power and high vacuum can be used for the divide and conquer technique. Now for sculpting, yes, keep vacuum less than 200. If it is more, then sculpting is difficult, especially in the soft cataract, and power should be less, 30 to 40. Then stop and chop. Single deep trench is made, nucleus bisected along it, and 2 heminucleus are chopped. See, advantage is lesser Pico energy. Now Pico Dynamics here, high power initially to trench, and then high level of vacuum can be used for the removal of the remaining pieces. Now see here, you can see there is a longitudinal and the torsional Pico is there. And what I'm doing is, see here, I'm going inside the nucleus and then making a vertical chop. Can you see here? See here. And separating up to the center. Unless and until you separate up to the center, that piece is not separated. Otherwise, when you are taking one piece, other piece will go down and tear the piece in. You will feel you have not touched why it has happened. It is because of the sharp edge of the tip, which was othered, and that can cause. Now see here, the pieces are separated, and after that, now here you can see the vacuum I am using. Then you can hear now the torsional and even the longitudinal Pico is using near about the 75. I am using here, and the vacuum you have seen in the first, it was 600 use. Here now I am using from 250 to 400, and I'm taking piece one by one piece here. Though the nucleus is hardened nucleus, I can see here. Last piece, yes, you have to go slow and remove it. Then use adequate viscoelastic substance so that second day your cornea will be clear and transparent to protect the endothelium. Then the direct chop. Now vertical chop we always prefer. Here the Pico probe buried in the center of the nucleus, chopper on the top of the buried nucleus, tip away from the anterocapsular rim. You should not go inside the rim. Then the Pico energy required is less when compared to other technique. Now here you can use burst mode. If it is not in the Pico, you can use any other mode. Pico 2 with high level, a high vacuum, that is 400 to 500, once the nucleus is impelled to allow the chopping. Now here you will see the direct chop. Two type of chops are there. Traditional chop, you can see where is the chopper, and in the Pico quick chop you will see where is the chopper. It is near to the tip of the Pico. Now here you will see the direct direction of the force. Now here see, can see the rexis also, and see my Pico and chopper. See, chopper is just inside the, here you will see how it is moving. This is the vertical chop I am doing. Now see again, the tip is going in the Pico, and then the chopper is used to separate it. So it is like a 90 degrees. See here, it is near to the Pico tip, and the chopper is separating the nucleus. So whenever you are chopping, see again, whenever you are chopping, you must see that these two instruments work together. And if they are working together, then it is possible to separate it out the small, it means 4 pieces, and then you can emulsify these 4 pieces. See here, I'm emulsifying the quadrants, what I have made, and you can make 2 quadrants or you can make 3 quadrants, and accordingly, see, you can do the Pico emulsification. Then the horizontal chop, Nagahara, we can use that. Normally, you can do it in the hypermature cataract. Pico probe buried in the center of the nucleus, chopper beyond anterocapsular rim, pull up the chopper towards the probe, and probe holds and separate the nucleus piece. See here, you must be able to see the edge, and in that, if you do the nucleus salute, in that it is possible to go for the horizontal chopping. Now this is what the position of the chopper you have seen in the, it is in the edge of the nucleus. This is the position of the chopper here, and then you can separate the nucleus. Now the tunnel assisted delivery of the IOL now deepens the anterior chamber with visco, and prior to the IOL insertion, you will have to put the visco. Now here I am using the AC maintainer and not visco. You will see the tunnel. It is a proper tunnel where the tunnel assisted nucleus, this lens I am implanting inside. See, the lens is implanted, and once the lens is inside, then now I will dial. As I am using the AC maintainer, then the visco is not much inside, but yes, whatever the visco is there, the see now I am cleaning from the anterior side, and then go behind the lens and also clean. Now this is the aspiration cannula I am using. I am not using the automated irrigation aspiration, but that can be also used. Now other is a hydrate side ports and tunnel well. Well from anterior chamber relaxes the surgeon. Otherwise, second day you can get hypotony. Safe surgery is the perfect surgery. So whatever happens, the surgery should be safe. Now the take-home message is observe, practice, and then learn. So don't go for the learning and then don't decide that learning will practice. It will never happen. Observe, practice, and then learn. Correct technique is very important. What you can do, the selection of AG case initially and stepwise conversation from SICS to FECO will definitely give success to you. Thank you very much. Thank you very much for permitting me and inviting me for the presentation.
Excellent presentation, sir. And this is just should be there in the manual of every budding cataract surgeon to start from the basic of step 1 and step 2. I particularly liked your comments on making the other hand also being valuable in the surgery, and we should all practice with both the hands. Knowing the machine is equally important, and I think each and every step of the surgery was so well covered by you that this should be almost like the Bible for cataract surgeons. There are certain comments and questions here. I think one question that pertains to is how would you deal with soft cataracts?
See, Gul, I always shift my soft cataract on table 2 because soft cataract is operated by Dr. Ragini. I deal with the hard cataract, and soft cataract I think I do in the VIP cases. But when there is a soft cataract and if it is a grade 1, see, normally one should not operate grade 1 cataract if it is not hampering the vision. But if you are operating grade 1 cataract, first, I will always advise bring one of the edge of the nucleus out, and that will be easy. Okay, technique 1. Secondly, if not, then trench in the center. Don't trench in the periphery. Trench in the center. See, in the center, nucleus is thick. So trench in the center and make the 2 pieces. And otherwise, what happens? Then you will create a saucer. And you know, if you create a saucer, in Marathi, saucer is called as a saucer. That is a mother-in-law. This mother-in-law is very difficult to bring it out. So that she will take the her daughter with her. So that is a vitreous. And to avoid that, always see that the saucer should not happen.
Lovely, sir. So also for different types of cataract, do you change the machine parameters? Of course, with your experience, I'm sure with any parameters, you would be able to manage any kind of cataract. But for the beginners, would you suggest that they should be changing their parameters?
See, I never change anything. But for the beginner, I will definitely tell, because there are now new machines, and in that, you must keep the soft cataract different thing, the medium cataract different thing, and hard cataract different thing. So here the soft cataract requires minimum phaco and maximum aspiration. You can say vacuum can be more. In the hard cataract, your phaco should be more, and here the aspiration should be less. So vacuum should be less. That is important, because here when there is a nuclear cataract you are operating. Secondly, I will tell them that when you are dealing with the hard cataract, your tip should be sharp. If you are dealing with the soft cataract, you can use any tip and blunt will be better, so that it will not tear the piece.
Exactly. There are various combinations one has to adapt, and I think there's what you can do is probably have many such classes for budding ophthalmologists, and maybe have a phaco training course at JJ Hospital with the volume and experience that you and Ragini have with both phaco and SICS. It could be a blessing for a lot of ophthalmologists, especially in Mumbai, to come to an institute and learn, get well trained for this.
The question in the box is that in the COVID era, after how many days we can operate the cataract when the patient is positive? See, when the patient is positive, we should not operate the patient immediately when he is negative. We can operate the patient. See, always said that we should operate the patient after 4 weeks of the patient, when patient has the can say COVID, and after that 4 weeks we can operate, not 2 months. After 4 weeks we can operate the patient when he was a positive before, and later on he is negative.
After vaccination also, She has also written
after
between vaccination and cataract surgery, ma'am has asked.
No, vaccination, yes. After vaccination, I think the we should do the cataract surgery after 2 weeks.
Thank you, sir.
Sir, also that we do RT-PCR twice before. So once the patient's RT-PCR is done before admission, the patient is admitted only if the patient is negative. And also X-ray tests are being done in all patients because the patient may be negative, but there may be X-ray findings. And after admission, also the patient's RT-PCR is repeated. So that is the protocol that we are following as advised by sir.
Including the vaccinated people? So
yes, everybody who's getting admitted has to get a RT-PCR before admission and on admission on the same day. Everybody, even if they are vaccinated.
Good. Sir, a wonderful presentation. I just wanted to ask one thing, sir. Have you been using moxifloxacin regularly for
I'm not using moxifloxacin I think this intracameral any drug in any case, but now I think from in the last OT I used in the 2 patients just to make an I can say research that how it works in the you can say in one-eyed patient and those patients who are having some problem. In that I'm using, but that is for the research purposes. But for any other purposes, I'm not using anything. But thanks God and the you can say the sterility technique by Ragini, though we are operating near about 14,000 cataract. Touch wood, we are not getting any complication, though Pritham is there, but we are getting complication of the nucleus drop. And this every day the Aswin, then the Pritham and Saili, they are there to help us, not endophthalmitis.
Thank you, sir.
thank you so much, sir. And Dr. Ragini for this excellent guidelines on cataract surgery. I'll hand over the mic back to Pritham for the next session.
Thank you, Dr. Gul. Again. Thank you. Can you hear me?
Yes, sir, we can hear you.
Yeah. So, so with this, we go on to the next session. And
yeah, Dr. Pritham, Dr. Bhatti sir has been here during the mentors talks also, but his video was not on.
Okay.
So Bhatti sir is also one of the mentors of the BOA. I think in 2000, they were the office bearers, Bhatti sir and sir, when they took over the BOA, and he is also a teacher and mentor to BOA. So we would like, he's going to speak first, but we would like to hear him speak, Pritham.
Yeah. So Dr. Bhatti sir, can you, few words from you?
Yes, Dr. Bhatti.
Yeah, I've been listening to all the lectures with great attention and I've learned a lot. And I don't have many original ideas, so I'll just reflect some more on what Dr. Nikhil Gokhale had said and some of the others had said. What Dr. Nikhil Gokhale had said applies to me also, that I still think of myself as a student. And even when I'm apparently teaching, I'm really using that opportunity to just crystallize my thoughts. And every time I take a lecture, I realize how much more I've missed in that lecture and how much more I need to learn. And I really learned a lot from the initial few talks. And of course, Dr. Lahani's and Dr. Ragini's talks, we always learn, so I don't need to specify that. But the first few talks were really, really very informative. And I learned a lot. And in continuation of what Dr. Manyar said, I remember another doha which says, Guru Gobind dohu khade kake lagu paye, balihari gur aapne jin Gobind diyo bataye. That means if you have God and the Guru in front of you, I mean, God is greater, of course, but you would rather pay attention to the Guru first because he's the one who teaches you the way to God. That means to perfection. And I think with that, I'll probably start my lecture.
Yes, so you can, Dr. Bhatti, so you can start sharing your slide. I would also like to invite the moderators for the session, Dr. Sujata Chahande. Welcome to Dr. Sujata, madam. And Dr. Chandrasekhar Bhavikar is here with us to moderate this session. Welcome, sir. And we have Dr. Rahul Baile. Is Dr. Rahul Baile join?
Yes, sir.
Yeah. How are you, Dr. Rahul? Good morning to you.
Good morning, all the teachers, and happy Teachers' Day to all my teachers.
Yeah. So we have these three prolific surgeons, Dr. Sujata, Dr. Vavikar sir, and Dr. Rahul, to moderate this session. And the session is on pan-ophthalmology. To start with, it is our own Dr. Bhatti sir, and he's going to speak on indirect ophthalmology, some interesting points. So we can see your slides, sir. Please start.
Most of the talks you had so far were packed with information and a lot of knowledge. Here, I'll just be emphasizing just a few points as to why indirect ophthalmoscopy should be learned by everybody and what are its advantages. As you all know, in indirect ophthalmoscopy, a convex aspheric, usually aspheric lens is used to create a real image of the retina in the air between the patient and the observer. And this particular way of observing the retina is responsible for most of the advantages of this technique. Here we have a slide which shows the arrangement of the lens, the patient, and the examiner. You have the lens close to the patient, and the examiner looks at the aerial image which lies between the lens and the examiner. And you can have a variety of lenses. You can have a 30 diopter lens, a 40 diopter lens, a 20 diopter lens, and a 15 diopter lens, and many other in-between powers as well. And these give you a certain magnification. Now, the nominal magnification of the image itself, you can derive by dividing 60 by the dioptric power of the lens. But again, the actual observed magnification would depend on the distance at which the examiner saw this aerial image. For presbyopes, of course, the matter is very simple. You just have to see them at the distance at which your presbyopic correction is, which will usually be 12 inches. And so you will get the stated magnifications. But for younger people, they can stretch their arms out and see at a longer distance too, in which case they get a slightly lesser magnification. And this diagram illustrates that. Now let's look at some points about the field of view and the magnification of different types of indirect lenses. The 15 diopter lens, which isn't commonly used, gives you the smallest field of view and also the largest magnification. So if you are a person who likes to look at glaucoma cases, or you want to look at the optic disc or the macula close-up, then you might want to use this lens. And you then have a 20 diopter lens, which is the standard one. And this gives you a slightly wider field of view than the 15 diopter, but still not a very, very wide field. With the 30 diopter, the field increases still more. And with a 40 diopter, it again increases a little bit more as well. So let's look at some pictures to illustrate the real appearance. I mean, it's all very well looking at these diagrams, but to get a feel of the matter, you have to look at the actual view. Now, this is a view of the fundus with a 15 diopter lens. And as you see, you can see details of the disc, you can see the cupping, and in certain cases, you can even see the lamina cribrosa. So there's quite a bit of detail seen. And things like AV changes, you can make them out pretty well. But the sweep is not very panoramic. The view is wider than a direct ophthalmoscope, but not all that wide. And here you have two pictures showing the same fundus with a 20 diopter lens and a 40 diopter lens. And you'll notice the 20 diopter lens gives you a little more magnification, and it has adequate field, but the 40 diopter lens gives you a much wider sweep. And what are the advantages of indirect ophthalmoscopy? We all are aware of them, but let's look at a few examples to illustrate it a little more clearly. First of all, you have a larger field of view than almost all viewing techniques. Some people like to use a 90 diopter lens on a slit lamp. That is also a way to do indirect ophthalmoscopy. Lenses like the mainstar lens are also methods of indirect ophthalmoscopy. But in all the slit lamp methods, though you get an extremely large view overall, but because of the narrowness of the slit beam, this view is not available to you all the time. You have to scan across the view to get, to see the entire fundus as seen in a single view. But with handheld indirect ophthalmoscopy, you get a large field of view illuminated side to side at one shot. This method of illumination is called total flashing, where the light focuses on the nodal point of the eye and then again diverges to illuminate the entire retina. So your field of view in handheld indirect ophthalmoscopy always covers the entire extent of the lens. The second thing is that binocularity is possible. Now, binocularity isn't always possible if you're using a handheld light source. That means if you're using a monocular light source or a torch or even a smartphone, binocularity won't usually be possible unless the patient is extremely dilated or he's a high myope, in which case you could get binocularity even with a naked eye view with a torch. But you can have a head mounted indirect ophthalmoscope, which allows you binocularity even through a normal dilated pupil and sometimes even through a undilated pupil. Now, how is this achieved? This is usually achieved by a placement of lenses or mirrors, which converts the normal IPD of the viewer, which would be about 60 mm, to a virtual IPD of about 15 mm. And in some cases, to a virtual IPD even narrower than that, so that you can view through a small pupil. Now, by giving you a virtual IPD of 15 mm, it ensures that any light from the retina after passage through the indirect ophthalmoscopic lens will have a sufficiently narrow cone so that it can enter both eyes at the same time, allowing binocularity. Another advantage of indirect ophthalmoscopy is that the periphery is easy to see. You just have to tilt the lens and you have to tilt the patient's eye and sometimes your head or the light, and you can see up to the equator or even beyond it quite easily. And with binocular indirect ophthalmoscopy, there is the additional advantage that you can use indentation techniques, which will allow you to see all the way up to the ura. Another advantage of indirect ophthalmoscopy is that because you're getting a relatively wide field, you can appreciate the relationship of all the structures. Now here, if this view was seen with a direct ophthalmoscope, it would be a bit difficult to see that the artery is climbing over the CSR edematous patch. But here it's very obvious that there's a central elevation. All the signs, although this is a uniocular picture, but all the uniocular clues to binocularity indicate to you that there is an elevation. You can see the subtle color changes in the fluid of the CSR. These wouldn't always be possible to appreciate with a direct ophthalmoscope, which gives you a very small view. And as you scan your view across, you can't appreciate the subtle color and other variations between the point you're viewing and the point you just viewed a little while back. And another advantage of indirect ophthalmoscopy is that the depth of field is very good. Now, pictures like this are extremely hard to appreciate with direct ophthalmoscopy. They are pretty hard to get even with a normal fundus camera. But in indirect ophthalmoscopy, you just select your choice of lens and you can pick up stunning views like this, which tell you exactly what is happening. Now here you can see a sommering ring lying in the fundus with a lens inside it, and all these details can be appreciated. You can also appreciate that this ring is lying pretty close to the retina and that it is vertically oriented and not flat. All these conclusions can be obtained by direct and other ophthalmoscopic views, but a lot harder to appreciate in one glance. Now the technique. In viewing indirect ophthalmoscopy, you first have to hold the lens in such a way that the entire eye is seen and you get a red glow in the middle. And then you move the lens away till the field completely covers the lens. So you can see this. You first get the red glow, then you move the lens until the field of view completely covers the lens. And you then get your view, which you can examine. And if you're using a smartphone or any other method, you can even freeze a frame. And of course, because you are having a virtual image in the air, you can also superimpose it with a real image. Now, this may be done deliberately, like in the picture on the left, where you've included a pen inside the picture. And this pen is actually casting a shadow on the image of the retina, right? It makes it really realistic. It looks like the pen is right inside the vitreous. And sometimes it can create artifacts like the hair in the fundus on the right. This hair is not actually in the fundus. It's the patient's hair, which is just coming in the field of view and appears to be superimposed on the fundus. So this particular interesting fact that you're looking at a real image in the air allows you to get these interesting artifacts and techniques. And thank you very much.
Wonderful photos as usual, Patti sir. Gokhale sir wants to know the exact technique how to capture the indirect ophthalmoscope and mobile photographs. In your words, like what are the some tips to make it very easy? Like, do you use a video mode on with a flashlight on and then capture it, or you take screenshots later?
The theory behind all the techniques is quite complex, but luckily for us with smartphones, the actual execution is extremely easy and boils down to 2 or 3 small tips. The first is that if you have an iPhone, then you have no choice. You have to record a video and then grab a frame from it afterwards. But if you have an Android phone, there are some apps available that allow you to keep the light of the camera on when you're taking a picture. Now, if you want to take single pictures, that is very necessary because if you don't have the light on, you can't see what you're photographing and you can't take a picture. So you have several apps. The app I like to use is an app called Footage. Because as you all know, with the normal Android stock camera, you cannot have the flash on all the time when taking a picture, right? It'll come on only when the picture is actually taken. And that's of no use because you can't see the fundus in that case. So this app allows you to have the light of the camera on all the time. Now you just look at the screen of the camera, use the camera as a light source and do indirect ophthalmoscopy with it. And when the picture looks good, you just take a picture. But all this, I'm sure many people have tried and they hadn't had very good results. So the couple of tips that you need to know to improve your results. First of all, do not use the exposure that the camera gives you, but downgrade that exposure by about -1. Most cameras and even the Footage app allows you to give a lower exposure. This prevents the washed out pictures that most people get when they use cameras. Now, as I said, the theory behind that would take a lot of time to explain why you go to -1 or 1.5. But in practice, you do it and you'll find much better pictures, especially pictures of the disc, which tend to get washed out otherwise. The second tip is that you zoom the picture till the IO picture covers almost the entire phone screen. Now, people who know a lot about photography would tell you that that zoom is empty zoom. You know, it's empty zoom in the sense that it's not actually adding any detail. It's only magnifying the picture, and you could as well do that afterwards. But the advantage of zooming in is that it would allow your camera's auto focus and auto exposure to work much better. That means, in other words, your camera's autofocus and auto exposure will work effectively when the picture is filling the entire phone screen, and they won't be that effective when the picture is small, because then the camera may focus on your fingers or on something else other than the picture.
But stop your screen sharing so that you can be seen.
Sir, unfortunately, my camera,
Okay, no problem. Go ahead.
It doesn't work, so you can't really see that. So the 2 tips would be use a -1 or a 1.25 or something exposure on the Footage app. Zoom till the view is filled up, and then when you get a nice view, just take a picture. Now, the other last tip, which is also pretty important, is that we always tend, because of force of habit, to hold the lens at arm's length. But that distance has to be varied depending upon the lens you're using. If you're using a 20D lens, you can more or less keep it at arm's length. If you're using a 40D lens, you have to go much, much closer. That means your lens, everything, your hand has to be cropped and you have to be close to the eye. And if you're using a 15D lens, then you have to stretch your arm really out, and possibly a short person with short arms may not even be able to get it far enough to get a good picture. Right? So these are just the few tips. You follow them, you'll get excellent pictures, and you don't need to really know the theory. But if anybody is interested in theory, there's another lecture for that.
Thank you, sir. Sir, quick comments by our moderators, Vavikar sir, followed by Sujata madam, and then we go on to the next topic.
Sir, excellent presentation as usual. It was nice to listen to Professor Bhatti after a very long time. Sir, how do you, can you talk a little bit about PVD? Because that is a very common thing.
You mean about PVD itself, or how to photograph a PVD?
No, diagnosing PVD on indirect.
I don't think there's much to it. You just see that little warped ring that looks like a bent rubber band lying on top of the disc, and that's about it. That's your diagnosis. If you wanted to be a little more detailed, and you would want to see a clear optical space between the vitreous and the retina, then you would probably require to use a slit lamp and a narrow beam to see all that. But as far as indirect ophthalmoscopy is concerned, PVD is just a round opacity on top of the disc, and it's extremely easy to see because of the good depth of field of the indirect ophthalmoscopic technique. I have some pictures also somewhere in my hard disk, but they'll take a lot of time to search, so I'm not showing them. But if I knew you were going to ask this question, I could have had a couple of pictures ready.
Thank you.
Can I make a small comment?
Yes.
Bhatti, you didn't allow us to zoom in on your face, by not showing your face itself.
Well, there are two reasons for that. One is that my webcam, I gave it away to somebody, the good one I had. And the other one I have is a pretty lousy one, and shows a lot of flare and all. And the second is that this allows me to sit in my undies without wearing a turban and all that stuff right on the screen and take the lecture.
We promise not to see you. Come on.
Well, when I say undies, I mean actually shorts, but the concept is the same.
Okay. We know what to give you for your next birthday.
Right.
So this is becoming like a Wednesday seminar with everybody, Wednesday afternoon tea with everybody being there. Bhatti sir.
Right, that's true.
Sujata madam.
Sir.
Yeah, good afternoon, sir, and a happy Teachers' Day to all my senior teachers and my colleagues. It's so much fun to see everyone on a Sunday, and especially on such an auspicious day. We normally, ma'am knows, we all meet up on a Teachers' Day, and we actually, have a good time with all our residents and students. However, that is not possible today, but this is still a good way of topping it up. And yes, Bhatti sir, what more can we say about him? He's always, with 35 years of experience. I would not just talk about the ophthalm part, but he has a vast experience throughout his career. And I don't think there's any topic in the world that he doesn't know of. You discuss tax with him, you discuss technology with him, you discuss photography, ophthalm, whatever you say, and he has an answer to it. So I don't think one session is enough for him, just that one topic, he'll split it into so many, from the camera point of view, from the microscope, from the patients, from the teaching. So I think we can have a series of lectures for one topic for Bhatti sir. So hats off to you, and you're always inspiring and always teaching. Every meeting, we always get to learn something from you. So thank you for all that, sir. And
I want to make another comment, if I may.
Yes, ma'am. Yes, ma'am.
Yeah, this is like, to go back 30 years back, almost 29, 30 years back, when I had an indirect ophthalmoscopy course. And whom did I approach? None other than Dr. Bhatti. And he was the one who helped me out to take pictures in those days. It was so difficult, but he was the one who helped me out. So like indirect ophthalmoscopy and photography have been his pet topics right from that time.
Ma'am, he also has this thing that he will always make it a very, doable and a reasonable modality. You don't need expensive gadgets to do it. He'll always find a way out for a commoner who won't have those things, and you can still, manage to get it. So that's the skill and the greatness of him, that he tries to find a way out for the lesser mortals.
Thank you, Dr. Bhatti. No better day to wish you rather than on Teachers' Day for all that you have done for us.
Thank you
Very well said, and so much more that he does. On every Thursday, he'll remind me that I'm coming, keep a case. He sits and assists and teaches residents. And he says, Ragini, you carry on, but I love to teach. And, you know, and like Sujata said, that he's a mentor for everything. So Bhatti sir is really a great teacher. Thank you, Bhatti sir.
At
Thank
this
you,
point,
Sujata. Thank you, Bhavi.
I'd like to give the obligatory thanks to Dr. Lahane, because till I joined JJ, I was missing the teaching part, because you had a choice at that time to either practice or be into full-time teaching, and I chose to practice. But Dr. Lahane has allowed me, like Dr. Nayak said, to both carry on having that professor tag as well as to teach, and I'm indeed obliged for that. And I also thank you all for your comments, which are really overwhelming.
Oh, sir, I mean, we must thank Lahane, sir, for you and he being friends, that, you know, only JJ and all of us have benefited from your being in JJ, sir, completely.
Sir has always been so magnanimous about everything and everybody.
Yeah, he is very shy.
So, Madam, next topic is by Dr. Himalini Saman, pediatric ophthalmologist and neuro-ophthalmologist, as an honorary at JJ since last 15 years, ex-JJ alumni, SN consultant, ex-SN alumni, and Madam is attached to JustLo, as well as she's the director at Team Associate. And I personally always look forward to hearing from her, because she has very crisp and to the point presentations. Over to you, Himalini Madam.
Gets her screen on. I think I agree with you, Swapnesh. You know, when the program has to be made, she's the first one. It's crisp, it's done, it is done in a day. She knows her speakers, and she's a wonderful teacher, and she devotes all her time to JJ, and you should see her pediatric OPDs and neuro-opthal, and she's forever evolving. You know, I remember last month they did a very difficult case. So she continuously learns. From the time that we used to mug Jaffe in the OT till today, she's always evolving.
I was just going to say that Happy Teachers Day, and it is such a privilege today to talk amongst you all, you know, because I really cherish my time in JJ, and I can't forget the days that Madam used to sit with me in the OT with the Jaffe book, and she used to actually read complications of cataract surgery with me, and we used to discuss a lot of physiology at that time. That time you had a lot of time on hand, and I also remember the days where we've tricked sir, and you know, we would be on call but actually go for a movie and then serve cataracts and all of that. So I can't forget those days. So my topic today is abduction deficit. How would you approach these patients? Can you see the slide?
Madam, it's a blank white slide.
Okay, wait. Now can you see?
Yes.
Okay. So abduction deficit is a sign, and one needs to determine what the underlying cause. So the objective of this presentation is to discuss a few interesting cases with abduction deficit in order to highlight our approach to reach a good diagnosis and enable a timely treatment. So my first case is that of a 60-year-old patient. He complained of sudden onset double vision. This double vision was constant. It was horizontal. It was binocular. He was a known hypertensive. So keeping this history in mind, on examination, he had a right convergent squint with a right eye abduction limitation. Pupils were normal. The fundus was normal. So basically, he had a right-sided lateral rectus palsy. This is the primary gaze of the patient, where you see in this picture, there's an abduction deficit here. The adduction seems okay and the pupils were okay. So with this history and this findings, the diagnosis was a right lateral rectus palsy, keeping in mind that the patient was 60 years old and that he was a hypertensive. I thought to myself that this most likely is an ischemic lateral rectus palsy. Decided to observe for a month. In the meanwhile, the patient was asked to follow up with a physician and advised to control his hypertension. I always start aspirin for such patients because they are the ones who are at a risk of stroke. So starting aspirin does not cause any harm. But I always tell when I'm observing a patient that please report back if there's a worsening of symptoms or if the patient does not improve. Promptly a month later, the patient came back, no improvement. So at this point, decided to do an MRI. So we did an MRI along with a contrast, and we found a small enhancing nodule seen near the anterior cavernous sinus. And this was most likely a pseudotumor. And this is what caused the lateral rectus palsy in this patient. And along with that, there was some Macular infarcts and petechial hemorrhages, which were suggestive of ischemic changes. However, the diagnosis in this case, the cause for lateral rectus palsy in this case was the inflammatory pseudotumor. So after reviewing the MRI, a full inflammatory workup was done. A CSF tap was done. All the above was normal. So the patient was then started on steroids, 60 milligrams a day in a tapering dose. And promptly, the abduction deficit improved. So what did I learn, or why am I presenting this case to you? When you see a diabetic patient or a hypertensive patient with a lateral rectus palsy, provided the rest of the fundus examination is normal, your first differential diagnosis is ischemic. All ischemic palsies can be observed and you don't need any urgent neuroimaging to be done. However, if the palsy does not improve within a month's time, or if there's a worsening of symptoms, you must get a neuroimaging done, and the neuroimaging of choice is MRI plus minus contrast. So that leads us to a question, whether all cranial nerve palsies should be neuroimaged. So this case reinforces my belief that all cranial nerve palsies which worsen or don't improve need to be neuroimaged. But in a case of a third nerve, if you come across a third nerve palsy, pupil involving or pupil sparing, third nerve palsy is a medical emergency and should be neuroimaged without delay. The investigation of choice in that case would be an MRI, and if normal, to go ahead and do an MRI angio to rule out a PCOM aneurysm. The second case is that of a 14-year-old child who complained of sudden onset horizontal double vision. We specifically asked for any history of fever, and she said there was no history of fever. Her vision was 6/6 and the rest of the ocular examination was normal. The cover test revealed an esotropia, and based on the above findings, she was asked to neuroimage. So basically, this child had a bilateral lateral rectus palsy. So this is the primary gaze of the patient. And this is the side gaze of the patient. You see the abduction limitation was on both the sides. So this was a bilateral lateral rectus palsy, sudden onset, but otherwise a healthy child. The fundus was normal. So I still asked her to get a neuroimaging done. And while she was waiting for her neuroimaging, the fundus was normal. And while the patient was scheduled for neuroimaging, which was going to happen about 7 days later, at least a screening CT scan was done, which was normal. Now, a couple of days later, while she was waiting, she suddenly presented to the emergency department with drowsiness, severe headache, and persistent double vision. At that point, an urgent MRI was advised. So the MRI at that point revealed that there were extensive areas of leptomeningeal enhancement, as you see in this picture. All this is leptomeningeal enhancement, which means that there was inflammation. And when you see this kind of leptomeningeal enhancement, it points towards TB. Unfortunately, we couldn't see an enhancement of the sixth nerve because that was not documented, as the MRI cuts taken were too thick. So what did I learn? When you are sending a patient to a radiologist to get an MRI done, a clear communication has to be between the ophthalmologist and the radiologist as to what is your diagnosis and what would you like the radiologist to look for. In these kind of cranial nerve palsies, in general, there is no role of CT scan. So after performing all the investigations, the proteins were high in the CSF and the lymphocytes were raised, the glucose was low. All this is suggestive of TB. The gene expert and the pyrosequencing both confirmed the diagnosis of TB. So this child was immediately started with AKT treatment, supplemented with IV steroids, and a follow-up visit, her vision was 6/6 and the abduction deficit was present, but it was much less. So this is the picture of the patient post-treatment, and you see that the abduction deficit on both the sides is there, but it is very mild. And this was around 2 weeks after starting the AKT along with the steroids. So the discussion is that TB meningitis is associated with increased mortality and morbidity. And because of its variable and broad clinical spectrum, sometimes early diagnosis may be difficult. Unilateral or bilateral 6-nerve palsies can be false localizing sign. And therefore, the fundus examination is very important, because if you find a disc edema in these patients, then it is probably a papilledema. And the lateral rectus palsy is a false localizing sign. Increased proteins in the CSF along with gyral enhancement, as you saw in this patient, are classical features of TBM. Why did the patient present with a bilateral 6-nerve palsy? So cranial nerve palsies do occur in about 20 to 30% of the patients and may be the presenting sign of TB meningitis. And the pathogenesis is that the gelatinous exudate cause the entrapment of the cranial nerve. The 6th nerve is commonly involved followed by the 3rd nerve, and probably because of their long course. But a bilateral involvement of the 6th nerve is rare in TBM, and that's why the interest in my case for presentation. The fundus examination is very important to rule out papilledema, in which the setting of bilateral lateral rectus palsy is only a false localizing sign. Going on to the 3rd case, this was a young girl. She was overweight. She complained of headache, horizontal diplopia, which was constant. Vision was 6/6 but blurred in the right eye. Left eye was normal. Pupils and color vision were normal. The cover test again revealed a small right esotropia with abduction deficit. So this is what the young girl looked like. You see that little abduction deficit here. So she had a right-sided lateral rectus palsy. When we took a look at her fundus, the fundus revealed a bilateral disc edema, the right side being more than the left. And if you take a look at this patient, she was overweight. And a closer look at this patient, look at this pigmentation on her neck. It is a classical sign of insulin resistance. And then on asking her for more history, she said that she did have PCOD, for which she was taking treatment irregularly. So looking at a lateral rectus palsy along with a disc edema with an overweight patient, the diagnosis is staring at my face of a benign intracranial hypertension. So how does one approach these patients? You have to get an MRI done. If the MRI is normal, don't stop. Go ahead and do an MRI venogram also. It is mandatory to do a MRI venogram, although clinically she looked like a benign intracranial hypertension, because very often some of these patients may also have a sinus venous thrombosis, which you want to rule out. If your MRI venogram is normal, then go ahead with a CSF tap, document the opening pressure. If the pressure is high, it is your diagnosis of benign intracranial hypertension is confirmed. So this is what her venogram was. Her venogram study was normal. The patient was diagnosed as intracranial hypertension. She was treated with Dimox. She was counseled to meet an endocrinologist for her PCOD problem. Weight loss remains the mainstay of treatment for benign intracranial hypertension. There is no role of steroids. On starting the Dimox, within 2 weeks, her disc edema resolved. The last case is that of parents noticing their child not being able to turn both his eyes outwards since 1 year. The diagnosed elsewhere as bilateral lateral rectus palsy and was extensively investigated, including neuroimaging, all of which was normal. The patient then came for a second opinion. The vision and fundus were normal. This is what the primary gaze looked like. There is abduction limitation here and there is abduction limitation here. But if you take a more closer look at this child, there is narrowing of the palpebral fissure when he tries to abduct this eye. And there is an inferior oblique overaction here, which meant that this was like a leash effect. So what this child had was a bilateral Duans and not really a lateral rectus palsy. Hence, no neuroimaging required. This picture is just to bring to your attention that a lot of times infantile esotropias or long-standing esotropias may present with a little abduction deficit like this. And these patients are commonly mistaken for a lateral rectus palsy and advised neuroimaging. But if you simply cover the good eye and coax the child to look a little bit more outside, you will see that the abduction deficit disappears. So this is one way of knowing that this is not really a true lateral rectus palsy. So to summarize, abduction deficit is only a sign. It has several causes, and a correct and a planned approach is required for determining the underlying cause. Beware of the Duane's and infantile esotropia because they are often confused with laterectus palsy. And in all your differential diagnosis for an abduction deficit acquired, myasthenia should always figure in your DD list. Thank you.
Thank you, madam. Karobi madam had a question to ask. If she's around, she can just unmute and ask. She was asking, is there any harm in doing neuroimaging in all cases at the presentation rather than waiting?
Not Duane's, but the other cases where you get a lateral rectus suddenly out of the blue, you know, where they've not had it before.
No,
Why can't you do the neuroimaging right at the outset?
You could do the neuroimaging at the onset itself. The only reason why I don't do the neuroimaging is keeping the cost in mind. But if the cost is not a problem, then definitely you could go ahead doing a neuroimaging MRI with a contrast.
And in Duane's, what do you generally operate if they have a head posture, or you do?
No, head posture is
for them.
Head posture is an indication for surgery. Head posture with the strabismus in the primary gaze is an indication for surgery.
So what kind of surgery do you do?
So always a recession. The dictum on Duane's is to never do a resection, but to always do a recession. So either a medial rectus recession plus minus with a superior rectus transposition to the lateral rectus. So when you do a superior rectus transposition to the lateral rectus, they say that there is, you know, some abduction improvement is there, but it depends on what the angle is, whether you require one muscle or two muscle surgery.
Thank you.
But never a resection.
Vavika sir.
Excellent presentation, Dr. Hemalini. Especially these 4 cases what you showed, this is what we get every now and then in our clinic. I'll like to talk about Dr. Karobi's question. Even I am in favor of doing neuroimaging early. Unless I know the patient has got a lot of faith in me, because then the patient goes, if he does not get quick fix, he goes to another doctor, and when the doctor advises MRI, even with whatever good intention, then you look like you are a dumb or a negligent person.
I agree. The only reason I would say that I would not do an MRI instantly is keeping the cost factor in mind. If the cost factor is not a problem, then go ahead and do the neuroimaging. There is no harm at all.
Absolutely. See, if the patient, I know this patient has been there with me for a long time and he has got enough faith in me, then I would tell him like this only, that I would actually talk about money to him, that why we may be able to save the money. Let us wait for some time, 1 or 2 weeks. That is absolutely correct.
Agreed. And the only other take home point is that a lot of times to cut costs, people do a CT scan. A CT scan will give you no information. So if you're really trying to cut costs for the patient, then you might as well get an MRI done instead of first getting the CT scan done, being reported normal, and then getting an MRI done.
Beautiful cases,
Sorry?
Beautiful cases, I said.
Thank you, ma'am.
Your choice of cases was excellent.
Just one word, one comment is that, keeping the relevant scenario in mind today with COVID, in our OPD in JJ as well as in private, we're seeing a large number of double vision patients with transient cranial nerve palsies, particularly lateral rectus and superior oblique. I've not yet seen a third nerve, but lateral rectus and superior oblique post-vaccination or post-COVID immediately within a few weeks, and then getting better on its own. So that is just something. Anybody else from the panel has come across such cases? Ma'am, have you seen?
COVID is,
cranial nerve palsies.
COVID cases or even post-vaccination, we are getting all the funny kind of presentation, starting from transient, nerve palsies to even optic neuritis and papillitis. And we are all treating them. But luckily, what is happening that the prognosis appears to be good. They come out very fast.
They are recovering well, but I'm seeing a large number of double vision patients as compared to pre-COVID.
Yes.
I mean, it could be just a random thing, but I'm just seeing a large number of patients.
Yes, I agree with you. Swapnesh?
Yes, sir. So we can go on to the next topic. Thank you, Hemalini madam, for those wonderful cases.
Thank you, Swapnesh.
Thank you, Emma. Dr. Rahul Baile is also here.
Yes. Rahul? Yes. Have you come across any of these post-COVID syndromes?
We have seen 2-3 patients of papillitis, and one of the patients was having some palsies, lateral rectus palsy, and we immediately took opinion from one of the neurologists nearby to us, and they recovered very fast. And the neurologist said it is because probably of the antibodies which are developed for the COVID vaccines, and that those antibodies work like an autoimmune type of reactions, and that could give rise to such kind of scenario. But they recovered very fast without giving any treatment.
Madam,
Yeah, just to share this one case, there's a doctor who had developed COVID, and he had something like query fungal infection in the sinuses, and they went ahead and did a FES for him. And after that, everything was clear because the aspirate came negative for fungus. So then they decided that it was not a black fungus which was growing over there. And after that, for nearly a month, he manifested with fleeting kind of palsies of the cranial nerves. Means first one, his lateral rectus was involved. The next time, his superior rectus was involved. I mean, it kept the scenario kept changing. So we had repeated his MRI scans and all, but it did not provide any kind of information. But that was one case which was very confounding because even the neurosurgeon didn't know why this was happening. And he was at least, I think, about 2 months post-COVID when these things, he had this COVID infection. But 2 months later, he was developing all these kind of scenarios. So it's something which is very mind-boggling. You really don't know what happens with this particular virus.
What was the final diagnosis?
I mean, the patient still has a little bit of ptosis in one eye. And because the FES was done, the leveling of the eye has gone for a toss. One is a little hypo, one is a little hyper. So basically no conclusions as yet.
Thank you.
Hi, Kuresh.
Hi, Karabi. Hi.
Ragini madam, would you introduce Dr. Deepak Bhatt sir? He is our next speaker, speaking on diagnostics in ophthalmology.
Good afternoon, Dr. Kuresh sir. Thank you for joining, sir.
Good afternoon, Ragini. Sorry, I was in an eye camp. I'm feeling so thrilled. The first time that we had an eye camp in 2 years at Masina. It was regulated with social distancing, 10 patients per hour called and seen in 2 rooms, but it was great. Just doing something like that felt great. Yeah.
Yeah, Kuresh, you're feeling human, I think. You're looking also human.
Yeah, I just came home, had a wash, and then donned a t-shirt and Ragini giving me a 1 o'clock deadline. Before 1 you joined. So I said, okay, I must.
No, sir, we are running slightly late, so it's good. So thank you for joining. And sir, as we said, like Dr. Bhatti sir also just spoke, and you are one of the mentors of BOA. Because of you, that BOA has grown. And would you like to say something about this BOA webinar, the Gurukul, which is the brainchild of Swapnesh and Pritam? And it is because of you that BOA has grown so much, and we are all really pleased to be working under your guidance, and no other day than Teachers' Day to start this series, sir.
No, it's a wonderful idea and concept. I just want to tell all the new members of BOA and the youngsters who are there that please be proud of your organization because it is very unique in the country. I say this every time at every forum. We are not like the Delhi Ophthalmic or the Bangalore Ophthalmic or the TNOA or whatever. We are so unique that we are one big happy family. We fight, we do jagda, but all that within the confines of JJ OPD, 5 days before a conference. But except for that one occasion in a year which we reserve for jagda jagdi, the rest of the year is one big happy family, and which is unique because whatever goes on in that one room in JJ on 5 days prior to a conference is just because everyone wants to do better than the best for the conference. So amazing how everyone comes together in BOA. Even this Gurukul movement, would be difficult to imagine in any other scientific society where we are honoring our gurus and we are taking the Shishya, Guru Shishya concept forward. And everyone, whether it is Deepak Bhatt or Swaranjit or anyone, are most willing to share their knowledge anytime on short notice or whatever. So I once again just wish many happy years for the BOA to remain like this, one strong, united family. It doesn't matter who is the president, who is not. It is unique also that I would say about 50% of the BOA members don't know who the president and secretary is. Because it doesn't matter. The work is going on. There are webinars flowing. There is sometimes Ragini's face there, sometimes Pritam, sometimes Swapnesh. It doesn't matter, but work just keeps on just going on. So I just hope that this spirit of camaraderie which we have, this friendship unique that we have as one family, will continue forever and ever in BOA. And my best wishes on the occasion of Teachers' Day. Thank you.
Suresh, to add to your comment, a little bit of jagda is necessary.
Absolutely. Absolutely. It's a unique. I enjoy that. I come there only for the jagda jagdi which takes place.
So I think it is an uninterrupted, interrupted only because of COVID, and that also because of Sir's busy schedule. Otherwise, the Monday tea with Quresh sir and Dr. Lane sir has been uninterrupted. And the Monday teas in COVID also have stopped, not because of Quresh sir, it's because of Lane sir.
Exactly. I also feel I shouldn't burden him with my...
Anything goes wrong in BOE is Dr. Lane. That is the problem.
Sir, but when everything goes right also, it is Dr. Lane.
Dr. Lane. No, sir, everything goes right because of you, but only the Monday teas have been interrupted because Quresh sir has called me many times. Ragini, ye chai band ho gaya, mujhe chai ko aana hai, sir, kidhar bhag rahe hain.
Now I am free, Quresh, come for the tea.
मैं आता हूँ. Okay.
So Quresh sir, I think you put everything in a nutshell, and you so rightly said that it really doesn't matter who's the president or the secretary, because frankly speaking, this is the main essence of BOA, that there is a core group of mentors who mentor all of us, who let us grow and who let us work under your care and guidance. Thank you so much, sir.
Thank you. So thank you for those words, Dr. Ragini, and those wonderful words, Dr. Quresh. When Dr. Quresh was and Dr. Ragini were talking right now, it reminded me of one, actually a true event. When the great inventor, can you hear me?
Very well.
Yes, we can hear you.
When the great inventor Thomas Alva Edison, who invented the electric bulb and all, he had so many patents to his name. He was asked by a reporter that, which is your best invention till date in your life. So without batting an eyelid, he said, my best invention was Michael Faraday. So the reporter didn't understand, what do you mean Michael Faraday? Like he's your student, but he's your competitor now. So what he meant was his own student, Michael Faraday, went on to have more patents than Thomas Alva Edison himself. So for him, his best invention was his student. So, now today I'm sure there are a lot of students and young ophthalmologists watching this program, and it is like a clarion call. I would challenge each one, and I would tell each one that think yourself to be Thomas Alva Edison, and your lifetime at least create 5 Michael Faradays. So with that note, I invite none other than our dear Dr. Deepak Bhatt. I think he requires no introduction. If anybody and whoever is a eye doctor or anything to do with ophthalmology on this planet knows Dr. Deepak Bhatt.
And if they don't know Dr. Deepak Bhatt, then they have to stand in the corner with one leg up.
Absolutely. So his topic for today is approach to diagnostics in ophthalmology. I don't know how he's going to cover that in 12 minutes. It is like, it reminds me of that movie Around the World in 7 days or something like that. So, but only he can complete that in 12 minutes. Let me say that also. So, Dr. Bhatt sir.
Okay. Thanks.
Would you like to share your screen? Yes.
Yeah. Hi. Yeah, thanks. So, Preetham, can you? Yeah.
Yes, yes,
Can
you
you
can see
see?
your screen. Yeah, yeah.
Yes, yes. Okay. Okay, thanks, Preetham. That was were too kind. And I am also too confused how to put it in 10 minutes, what took me 33 years to learn. I don't know whether I learned or not, but it took me 33 years to get a hold of what is going on. Today being Teachers' Day, actually, from what Quresh said, each and every member of Bombay Ophthalmic Society, probably around, is being my teacher. I, being a radiologist, had no concept whatsoever of what is ophthalmic imaging till each and everyone taught me over so many years something or the other, which I have not learned from any books. So that's something some will share just now, and let's see how much I can cover. So let's start with ultrasound of the eye. So ultrasound, we all know, I look from a different point of view. I see what is seen on the screen and then go back and see what is history. Whereas when you all do ultrasound, you all have clinically examined the patient and then go to ultrasound. So there is somewhere a meeting point in between. But the ultrasound in the eye is fantastic because it was the first organ to be scanned by ultrasound in the human body. And it has vitreous, which has a fantastic medium for ultrasound. So we have echoes, membranes, and mass lesions. Very simple. I talked about it earlier. As I said, I'm going the reverse way around. When you see echoes, what will you look for clinically? So these are the history questions one needs to ask whenever one sees vitreous echoes, something like this. And as from a radiologist point of view, you'll always see all echoes are hemorrhage unless proved otherwise. But till you ask the actual history, you will never come to know what they are. So this, in short, are 4 different types of vitreous echoes that we will see. Okay, these are just distinct vitreous echoes spread out completely into the vitreous cavity. These are some clumped up vitreous echoes here, and in the periphery, these are clumped up in the center, and these are very bright echoes. Now, this is something which took me 5-7 years to learn. Again, I tell you, everybody in BOA has helped me out to learn this out, that these are floaters, okay? And this is inflammation, this is hemorrhage, and this is asteroid hyalosis. I remember my reports in 1993-94 when I saw my first case of asteroid hyalosis, and I have reported that as vitreous hemorrhage because I didn't know what was asteroid, okay? And the ophthalmologist called me up and said, "Sala, तेरे को समझता नहीं है, अंदर कुछ नहीं है." Patient coming and telling me मेरे आँख में खून है और मैंने तो कभी कुछ खून देखा नहीं उसकी आँख में. So this is how I learned the other way around. So asteroid hyalosis are very bright echoes which look like vitreous hemorrhage. None of the vitreous hemorrhage will have so much echogenicity as an asteroid hyalosis. And in front of the retina, you will always see an echo poor vitreous, where it never exists in a case of vitreous hemorrhage or inflammation. So this is something which is not mentioned in any books, but this is something that I learned over a period of time. Okay. Vitreous inflammation always will start near the vitreous in front of the chorioretinal layer, and therefore then it causes thickening of the chorioretinal layer and goes to endophthalmitis. Whereas vitreous hemorrhage will always be in the center of the vitreous cavity. So this is how one can differentiate. But again, I tell you, ultrasound is not a mode to differentiate between hemorrhage and inflammation. It's always the clinical history which determines that. And when you exclude all these 3 and patient has no other history, but maybe an opaque media or a dense cataract, then whatever remains here is floaters. So this is the other way, learning it in a reverse way of vitreous echoes. And just to show you some very interesting images over a period of time, this doesn't require any explanation, a cyst and a scolex. And we've seen a lot of cysticercosis, and each and every organ of the eye has cysticercosis. And I have an entire collection right from the cornea down to the optic nerve and orbital cavity. Coming to membranes, again, I said history is very, very important. Any membrane in the retina till when I started doing ultrasound was retinal detachment unless proved otherwise. Okay, I didn't know something like vitreous detachment existed, but if you have seen the patient clinically, then it's probably easier to make out what is going on. But if the membrane is not attached to the disc, it's all very fine. But if the membrane is attached to the disc, over a period of time, what I have heard is there are so many methods of differentiating an RD from a PVD. Probably this is the most common question asked in the exams also. But only the first 2 points that I mentioned here have stood the test of time. 80-90% of times one should be absolutely clear whether it is an RD or PVD if one follows these 2 points. The first one is a thick uniform membrane. Look at this membrane. A thick uniform membrane. Put it in the mind, thick uniform membrane. It cannot be a PVD. A PVD is a thin undulating membrane. This has a very clear-cut attachment RD to the optic disc. This will have an irregular attachment to the optic disc. No after movements in RD except it is in the early stage, and free after movements in PVD. If these 2 points are remembered, one can probably solve all the problems. And this is the case of RD with a PVD. Going ahead, you sometimes never see a hole actually, like there see a case of horseshoe tear here, and we could pick it up on ultrasound also, the tear in the retina with the vitreous attached. So this is fantastic correlation. Now this is something that I brought over here. I can't cover entire imaging over here. This is something that I learned over a period of time. I used to get so many post-operative patients of retinal detachment, and I have made blunders, and I have learned out of those blunders. The blunders are very simple. Any membrane that you see after a vitrectomy is not an RD, even if it is attached to the optic disc. I had this membrane over here, which I reported as an RD, and the patient came after the ophthalmologist said that was not very convinced. Patient came after 15 days, and this membrane has disappeared. So having small serious elevations in the retina post vitrectomy is a very common thing. When you call a membrane an RD is when the echogenicity of that is very thick, uniform over its entire extent, and is quite bullous, then you call an RD. See these 2 membranes. This is not an RD post vitrectomy. This is an RD post vitrectomy. So this is something which has taken me a lot of time to really understand what is there, and a lot of cases with follow-up to differentiate one from the other. So I don't jump to a RD post vitrectomy immediately. This is called as a vitreous skirt. Some amount of vitreous always remains after a vitrectomy, and this was reported by me multiple times as a tractional retinal detachment anteriorly. But this is something that you always will see after a post-vitrectomized patient, especially anterior to the equator. And this is just simple vitreous hemorrhage post-vitrectomy. So this is something we learn over a period of time. So everybody is a Guruji in BOA in whatever little that I have learned up till now. So this is a case of choroidal melanoma. Why I brought this? Because this is one of the only tumors in the human body which can be diagnosed with certainty on ultrasound. And you can see that this cascading reflectivity is a hallmark of that. Just interesting cases: dislocated lens, dislocated intumescent lens, dislocated IOL, 3-in-1. Patient had history of trauma, vitreous hemorrhage, dislocated lens, and IOB. Okay. So these are just enlargement of the optic nerve, of the extraocular muscles. These are cysticercosis, and that is Graves' disease and myositis, where the tendon is not involved in Graves, but the tendon is involved in myositis. Now we come to OCT. I have just a couple of minutes left. Everybody knows everything about OCT, but just want to share you some very interesting images for you to remember. So macular edema, we all know that this is diffuse macular edema, CSME, exudates with a lot of cystoid spaces, may be there, may not be there. But then you have the second type, which is the cystoid macular edema. I'm going fast because students also know this by heart, so you don't want to go in detail. Tractional macular edema is something that OCT has really revolutionized. And somebody in the beginning, when the OCT came, told me that one of the probably the most important reason why you bind an OCT is that you convert a non-operative case into an operative case. Because this is something that you may not be able to see on directly on your indirect. But if you do a OCT, you know that there is a traction thing, and somebody whom you are going to give intravitreal gets converted into a vitrectomy. OCT angio came for a long period of time, was a big challenge for us, and we still do not know what that role is. But it does have a role even in diabetics. Is that something that I've learned over a period of time? There's a big question mark. How does it fare with FFA? A lot of people have reduced their FFA also, but so it cannot go beyond the equator, but still it can show you neovascularization, intraretinal or extraretinal very well with areas of non-perfusion. So it really requires a lot of will to be to really depend on this and do the treatment and not go to FFA. It's going to take some time, but I think OCT-A is there to stay, and it will slowly knock off that 1% of FFA that we are doing. NVD is also seen very well over here. So this is what I want to tell you. The initial images that I showed you of OCT-A were only in the center part. But now the machines are very good. We can make a good montage. This is a case of diabetic patient with a very good montage here that you can see all the neovascularizations, all the areas of non-perfusion, and probably this is the area that we are interested in treating. We will not go too much beyond the equator really in such type of patients. So it can give you a fairly good idea. It does not necessarily have to be like doubtful as of now. Vascular occlusion, simple thing. This is that very good image which I have taken from one of the journals. Really, any students looking out for you should actually take a picture of this and keep. How you differentiate between cotton wool spots, branch retinal artery occlusion, and PAM. The differentiation is very clear. Cotton wool is internal limiting membrane. Branch retinal is the entire area which is supplied by the superficial plexus, and the PAM involves only the deep plexus. Okay, so this is would make matters very easy. CSR, everybody knows what it is, right? And macular hole has actually OCT has revolutionized. It has changed the definition of macular hole from those 5 types that you used to see on slit lamp. It is now very simple. Either it is a foveal cyst, it's either an impending hole like this, attraction, or a full thickness hole. So these are only the 3 types of macular hole and an operculum here that we all know right now. Last 2 cases, then CNVM is the hot topic that everybody is looking out for. OCT-A is a very good supplement to a routine OCT examination, where even type 1 neovascularization can be seen very well on OCT-A with the good imaging techniques that we have right now. So this is classical type 1, and this is classical type 2, where you can see the membrane very well. Even the OCT is diagnostic, but this helps you in that. And finally, the role is to see the follow-up of CNVM. Now, it was running too fast, and I don't know how much I can cover, but just few interesting cases in 10 minutes from imaging. Thank you.
I think Dr. Deepak, but that was a fantastic presentation. Only you could have covered so many important aspects in such a short time.
Yeah.
You know, if the chair and everybody permits me, I'm going to tell them a small incident.
Yeah.
You know, which involves you. I was a fellow back in. So you can stop sharing. Yeah.
Yeah.
I was a fellow back in Shankar Netra Lab. Talking about the year 2000. And you know, that time, if you remember, UBM was very new, ultra biomicroscopy. And Shankar Netra had acquired the first UBM machine, and I think you were going to buy it soon.
Yeah.
And you know, we used to, as Vittorio, I was a fellow that time, and as Vittorio Retina fellow, we used to get just 1 month in diagnostics. And in that 1 month, 7 days posting was in UBM. And you know, we heard that this person from Bombay is going to come and observe UBM for 1 month. So we were all very miffed, you know. We were, and Dr. Moona Bende madam was in charge of UBM, and we were all scared of Dr. Moona Bende. No one could talk to her. But Sujata Guha was our batchmate. So we could at least complain to her and speak to her. So I went to Dr. Sujata Guha and said, what is this? We have spending here 2 years as fellow, and we are getting 7 days in UBM. और ये कौन आदमी है जो बॉम्बे से आ रहा है और 1 महीना UBM में गुजार रहा है? So you know what Sujata Guha told me in a typical, you know, in a Bengali style, she said, ये आदमी नहीं है, ये डॉक्टर दीपक भट्ट है. Dr. Sujata Guha was referring to the greatness of you, sir, Dr. Deepak Bhatt, sir. So hats off to you because your enthusiasm, whether it was ultrasound, whether it was UBM, whether it's OCT, whether it's wide field photography and OCT angiography, you know, your thirst for learning is just amazing. Hats off to you.
And Pritam, you know, like all of you, he's devoted to serving JJ and, you know, looking after the patients. And if any of our machines stop, you know, or there's a big line of patients going to his clinic and getting it done. So like all of you, he's, you know, done so much for the last 20 years for JJ.
Thanks everyone. Thanks.
Deepak, show your face.
अरे यार संडे को कैसे फेस दिखाने का? It's all very dangerous.
It's like batti sir. It's like batti sir.
Okay. हो गया.
अच्छा खासा face है.
Add something, sir.
ठीक है.
Deepak
दिखता है अभी.
sir knows how
Yes,
to
yes.
include humor in medicine. I mean, his lectures, however difficult the topic is, with his sense of humor and those easy tricks for students, he will always say, "Hi, ये सब confusion इसको छोड़ दो, सिर्फ इतना याद रखो." So it becomes the students can relate and they can actually answer in the exams. So that is the skill that he has. It makes it so easy for everyone to understand, and he takes pains and years to understand the topic, but for when he presents it, it is in the simplest of the form, which can be easily remembered. So that is the greatest, and I've known him from my PG days. We used to refer patients to him as PG students, and he's always been so accommodating and he's always so helpful for even the poor patients. And he's never said a no, never no for whatever time of the day or whatever the problem may be. Thank you so much, sir. Happy Teachers Day, sir.
Thank you all. Thanks a lot. Thanks a
Happy
lot.
Teachers Day, sir.
Thank you. Same to you.
So moving on to the
You
next
really
topic.
did justice to that 10 minutes. I mean, I was wondering how you'll cover all the modalities, but you managed it.
Yeah. Thanks a lot. Yeah.
So shall we move on then?
I think in the next Gurukul, you come with specific topics like, OCT one day, OCTA one day. It will be very helpful for everybody.
So moving
Thank
on
you.
to the
Thanks a
next,
lot.
Thank you, sir. Moving on to the next one. So we have none other than the rising star, that is Dr. Sumit Lahane, to give the next talk. Dr. Sumit is our alumni for postgrad from JJ Hospital, and then he went on to do his fellowships in oculoplasty with none other than Dr. Oculoplasty and Oncology with none other than Dr. Santosh Honawar, the world famed Dr. Santosh Honawar, and he's also done his cornea fellowship from Narayan Netralaya under the guidance of Dr. Rohit Shetty. He's doing fantastic work at JJ Hospital. He's the backbone of our PG teaching program, as well as he's the joint secretary of BOA, and some of his new ideas, of teaching and BOA webinars have really gone a long way. So I welcome Dr. Sumit, and he is going to speak on his favorite topic, ocular surface tumors, the good, bad, and the ugly.
So can I add? So
yes.
You have rightly said, and he's an all-rounder. He's a cataract surgeon. He's an oculoplasty surgeon. And in the last 16 months of COVID, he's not only the backbone of PG teaching, but the backbone of the department. When he's always around. So day before yesterday, I told him I have a webinar in cornea. So he stays up nights to do our presentations. Like today's presentation at 6 o'clock in the morning, he'll say, "Madam, it is on your mail." Yesterday's presentation, again, it was on my mail. And, he's not sleeping a single night because he's in the ICU with his grandmother every night for the last 16 months. And he's the first one to reach the department at 7 a.m. in the morning, whatever has happened. Without you, Sumit, these 16 months of COVID would have been extremely difficult. Your hard work, your dedication, your knowledge, your science, and your sweet nature when you say, कोई नहीं शांत रहो सब हो जाएगा मैम शांत हुआ सगळं होऊन जाणार. So when you keep us all sane and happy, so bless you so much, Sumit.
Can I make a comment? He's got
Yes,
his
ma'am,
dad's
please
genes.
go ahead.
He's got his dad's genes.
Absolutely. I don't want to put my guru down, but he's definitely like sir, and in some ways, he'll say, "I'll do it. Don't worry. I think he's definitely a multitasker like sir. Definitely, I agree with you totally, Karobi ma.
So good afternoon, everyone, and I would like to thank BOA, Preetham sir, Swapnesh sir, Ragini madam, and everyone. These are all here, my teachers with whom I learned the ABCD of ophthalmology, and it's an honor to present, and also the pressure to present in front of them, with them on the same platform. So thank you, Swapnesh sir, for including me in the program, and thank you, Karobi ma'am and Ragini ma'am, for the kind introduction. So we'll be dealing with the ocular surface tumors, the good, bad, and the ugly. Again, it's a huge topic, but we'll try to make few friends here. And what are the friends that we are going to make today? All this. Let's try and introduce ourselves to each one of them. They are not all bad and ugly. Few of them are good. Most of them are good. So when you see this kind of lesions, they appear a bit similar to each other, though they look different when seen together. But in the OPD, all these three patients will not come together to you. So when you want to differentiate, these are three different lesions. Now look at these two eyes, looking at the right and the left, and almost similar kind of a lesions. What are they? Which is good and which is bad? So when you have a two similar looking lesions, you don't have to focus on the large big things which appear similar, but you have to focus on something, a minute difference between them, to know that which lesion you need to treat and which you need not. So just let's go to the Civil War. What are the good lesions that we are looking at? And there are multiple lesions, and see, if a 17-year-old female comes with the increasing mass and the discoloration to your OPD, with what confidence you will be able to say that this is nothing to be worried about and you can go home? Maybe it's a small lesion, just a 3 millimeter in the size, and you can tell the patient. But what if the patient comes with such a large lesions of almost 1.2 centimeter, complaining that this is increasing in the size? And how do you know that now you need not treat it or you need to treat it? So there are certain telltale features of every lesion which tells you that do you need to treat or not. So this is what we are talking about, is the conjunctival nevus. So it appears in the first or the second decade of the life. It's located near the limbus in the interpalpebral area. There are feeder vessels. There are clear cysts, which is the most important feature of the conjunctival nevus. It grows, of course, the conjunctival nevus grows. It is not stagnant in the growth. It grows during puberty, pregnancy, and even the sun exposure. There is intrinsic vascularity, and the variable pigmentation are the most important features of a nevus, but it never encroaches on the cornea. Encroaching on the cornea is a bad sign for the nevus. And these are the cysts. If you are not able to find out on the slit lamp, then the OCT can help you to find out the cyst in the nevus. So when do you excise the nevus? There are certain indications. If it appears suddenly in the middle of the age, in the 40s, 45, or the later in the life, the uniform pigmentation is changed and it is completely darkly pigmented now. The locations are not in the interpalpebral area. Instead, now it is going to a pharyngeal area. It's more than 1 centimeter in the size, or it is involving the cornea for more than 3 clock hours. Exuberant feeders, no cyst suddenly, and the cosmetic are certain indications when you want to excise a nevus. In all, it's a good lesion to deal with. We do see this kind of feature multiple times and we do misses also, but this is nothing but a congenital ocular melanosis. Many times children present with that and we are not bothered, since it's a congenital lesion, may not progress. The pigmentation that we see in such cases is basically a uveal and the episcleral pigment and not a conjunctival pigment. Then why do we include it? It as an important lesion of the ocular surface? Just because the studies have shown that a patient with the congenital ocular melanosis imparts a risk of 1 in 400 for development of the uveal melanoma. So whenever you see a case of congenital ocular melanosis, you need to examine two more things in this patient. Important is see for a palatal pigmentation and second for the hairline pigmentation. Because these are the telltale signs that patient might have an intracerebral or the esophageal melanomas. Now you see this kind of pigmentation, dirty looking yellow conjunctiva. And this is nothing but a complexion related conjunctival pigmentation, another good lesion, nothing to be done about. What are the important things that we know that it is a conjunctival pigmentation? Just it's a variable color pigmentation. It's more concentrated around the limbus other than the other areas, and it is present all 360 degrees. But most important feature is it's a bilateral lesion. So you know this patient is generally exposed to the UV light more and have this kind of a complexion. It is nothing to be worried about a lesion. And then you see this kind of a lesion where there are feeder vessels and it is growing somewhere near the cornea. The way to diagnose it is nothing but the biopsy, and it is actually a conjunctival pseudoepitheliomatous hyperplasia. This happens, you need to take a proper history of the patients and they will give you a history of either a pterygium surgery or some foreign body or a rubbing of the eyes with some trauma, and a complete excision followed by cryotherapy with histopathological diagnosis constitutes the management of this kind of lesions. We do see again post-trauma such cysts, and these are basically nothing but the epithelial inclusion cyst. They can be very well excised or observed. They are benign, very good lesions of the conjunctiva, not to be worried about. We do see infantile capillary hemangioma primarily as an eyelid lesion or the orbital lesion, but they do reflect a part in the conjunctiva. Basically, they can be observed at the proper proliferative stage of the capillary hemangioma. They do increase in size, but later on they go into the remission and we don't have to do anything. But if they are increasing the size and patient is having ptosis and the problems with the visual axis, then we can definitely treat them with the oral beta blockers like propranolol or the topical Timolit. Now, these are certain very good lesions, and these are all epibulbar dermoids, epibulbar choriostoma basically. In the left-hand side, what I am showing is a dermoid. It's a grained one dermoid in the inferotemporal aspect that grows on the cornea. It causes a lot of astigmatism depending on the size of the dermoid, and it needs excision. It needs excision along with the sometimes double layer AMG or the tattooing for the cosmetic purpose. The next in the line, what we want to see here is a lipodermoid, again a congenital lesion, very, very slowly progressive. Sometimes the skin over gets keratinized and there are hair follicles growing on that. In such cases, the excision is indicated, followed by the ocular surface reconstruction. Osseous choriostoma is again a generally undiagnosed kind of a lesion. Even patient does not notice that they have this kind of a swelling. This is basically a bone growing there, and unless they try to palpate, they will not feel anything. And this kind of lesion generally we observe, we don't do anything. This though appears a very large lesion covering almost all of the cornea. This is a complex choriostoma which has a material of two different germ lines. It has a skin, sometimes eyelashes, sometimes cartilage, and everything that can grow on the cornea, and it needs a proper surface reconstruction. If not treated early, the patient generally develops amblyopia, and the management of the vision per se is difficult in such cases. The scary looking lesion is basically a lacrimal gland choriostoma, again a rare lesion, but can grow into the anterior chamber, and the only way to diagnose is doing a biopsy. Saying all these are good lesions. They don't metastasize, they don't progress much. Now let's move on to the bad lesions. Now what is this? A yellowish brownish colored lesion staying little away from the cornea limbus. Is basically a primary acquired melanosis, nowadays known as an intraepithelial melanocytic proliferation as per pathologist. This manifests in the middle age somewhere. They are unilateral, superficial, solitary. We need to be worried about that, especially when they are in the fornix and the palpebral conjunctiva, and if they are diffuse or patchy, involving more of a corneal cloacas. Now, why should we worry about the PAM? There are many of the cases that come in the OPD with the PAM. Do we need to treat everyone? No. But do we need to observe everyone? Yes, of course. So any PAM presenting with the lesion diameter more than 5 mm, involving the cornea, personal history of a cutaneous or the uveal melanoma, or even a family history, and there is a documented progression by an ophthalmologist that this is increasing in size, does warrant an excision along with the cryotherapy. Actinic keratosis, again, it's a very common lesion that we see. Basically, though it looks very benign, but it's a pre-malignant lesion, happens because of the ultraviolet light exposure, and it's a relative indication for a surgical excision and the supplemental cryotherapy. Again, this is a bilateral present both on the nasal and the temporal side of the limbus. Now, what are the ugly lesions? This homogeneously dark lesion growing on the cornea is nothing but a conjunctival melanoma. Now, why I was putting PAM as a bad lesion? But because 75% of the conjunctival melanoma, they do arise from the PAM. And there is the dark uniform pigmentation, growth on the cornea, large feeder vessels, and this does need a excision biopsy. This is just a small mnemonic to not to miss a conjunctival melanoma when we see. Now, what is this? Looking at the size of the lesion and the aggressiveness, we know what we are looking at is a neoplastic lesion, but the signs does not change. There are feeder vessels, there is a rose Bengal stain positive, growth over the cornea of the lesion, and the keratin present. Presence of all these four signs basically tell you that what are you looking at is nothing but the ocular surface squamous neoplasia, and the clinical way of diagnosis with all these four findings is with the increased sensitivity of almost 95 to 97% that you know what are you dealing with is basically OSSM. Now coming back to these two lesions, and one of this we already classified as a pseudoepitheliomatous hyperplasia. Now this other lesion, if you just magnify and see the four signs that I told you, again there are feeder vessels, keratin, vascularity, rose Bengal, and it tells you OSSM. So despite of the lesion being a small or the large, the signs does not change. So you know what to be seen in this patient. You will never miss a diagnosis of OSSN. Now, OSSN basically, there are multiple ways of treatment. I have just covered the surgical aspect. How do we treat? We treat with the excision of the tumor with the 4 millimeter clear margin, double freeze thaw cryotherapy, alcohol keratoepitheliotomy, plus minus partial lamellar sclerectomy, depending on the involvement of the lesion. And the most important is histopathological confirmation, because any malignant lesion is not the treatment is not over unless you do a proper histopathology and you get a margin in the base free of the tumor. Now, what is this? Again, a very pinkish, healthy, cute looking lesion. This is nothing but you try to treat with the steroid. This will never disappear. This slightly elevated, resembling a smoked Malman patch, is nothing but a conjunctival lymphoma. It presents unilaterally in 70% of the cases and bilaterally 47% of the cases. Why it is important? Because the bilateral cases has more risk of development of the systemic lymphoma, which develops in such cases in 15% of the patients in 5 years and 28% almost in 10 years. So this kind of lesion does need a treatment, excision biopsy, and of course systemic workup to rule out a systemic lymphoma. So we of course introduced to all these lesions, and the basic nature of the lesions, the most of them are good. Very few of them are bad and ugly. If you know the signs, you will never miss any of this lesion. So to conclude, you examine every conjunctival lesion very carefully. Photographic documentation, whether you try to diagnose, whether you are able to diagnose or not, it's very important. Always keep a high index of suspicion, especially with the lesions which are not disappearing and increasing in the size over a period of time. And biopsy when needed, especially in non-responding lesion, is very important. I thank you all my mentors to make me able to present here in front of all of you. And I thank you for the opportunity. Thank you, everyone.
Excellent presentation, Sumit. What a great collection of photos. And truly, you are an asset to JJ Hospital. Vavikar, sir, your comments?
Excellent presentation, really good. And the way he presented, divided them into good, bad, and the ugly is very useful in day-to-day practice. Thank you, Sumit.
Thank you.
Rahul Baile.
Yeah.
Dr.
Sumit,
Rahul.
I have a question for you. I have seen many patients who are having small conjunctival cysts, which are torturous, and they come to OPD with a complaint of continuous irritation and watering. And whatever kind of treatment is given, those cysts does not vanish, and they keep on troubling them. What are those cysts, and how to treat them?
Generally, sir, what is the location of such a cyst? Is it near?
I have seen some cyst inferiorly in the pharyngeal area on the conjunctival side, and some nasally, some temporally. There is no specific location.
Okay.
And they are very tiny.
They just look like a bubble.
Yeah, definitely. They just look like a bubble. Yes. But these patients trouble a lot.
Yeah. So basically, those are lymphangiectasias. Okay, the conjunctival lymphatic sometimes get dilated, and the that you see is basically like a bubble. So not all the patients have this foreign body and gritty sensation, but if at all they are complaining again and again, then of course you can do a simple excision in such cases. But you do tell the patient that this lymph, the patients have a tendency to develop recurrence in such cases. So you can just do a simple small cryotherapy along with, and that will take care of the patient sensation. But generally the indication is, unless otherwise patient is not happy with the TR substitutes, then only you try to excise this cyst.
Okay, yeah. That's.
Sumit, should we excise it, or can we just drain it with a needle? Will it reoccur?
Draining will not help, because they will come back very next day. So the excision will be a better thing to do in such cases.
Thank you.
Sumit, I wanted to add something. A lot of patients do come with these kind of little cysts. I always give them a trial of drainage, means just in the OPD, you stick in a 26 gauge needle and drain it, but with a clear understanding to them that I'll do it only twice. If it occurs a third time, it has to be excised, So the thing is, you do it, and many of them don't recur. So it's worthwhile taking a chance and just draining it off at that point of time.
Okay, ma'am. If it works as, but in the lymphangiectasia, it is very well known thing that they do reoccur. My timeline might be different for everyone, but if the symptom resolve with a simple effect, it is good. Generally, they are those so soft that they should not cause any foreign body sensation. So basically, any placebo works. Even if you want to change it or tear substitute to the gel, most of it works. So if the aspiration works, whether as a treatment or whether as a placebo, it's well and good, ma'am. Whatever is, because they are harmless lesions. In a way, they are very good lesions to treat.
Excellent talk,
Just to
Sumit.
add, Sumit was an excellent presentation, and one word for Sumit is he has ice on his head and sugar on his tongue. So he was posted with me, and I remember for anything that comes up, he would never be disturbed. He's so cool, Ragini ma'am just said it exactly, like, he will not get boggled by anything. Think, oh, theek hai, madam, hota karta, and he'd always find a way out. And we all, from this, in the COVID era, we were struggling with the virtual CMEs and presentations, and he was always like, okay, no, ma'am, I'll sort it for you. And he would always be so helpful. So thanks, Sumit, and an excellent presentation. You did show you. I don't think there's an ugly side to you. I've seen the good side only, but it was a good presentation to show the good, bad, and the ugly for the patients, for the students' point of view. Thank you so much.
Thank you, sir.
So our next presenter is Dr. Priyanka, and she would be talking on the perimetry and the visual field effects in glaucoma. Sumit, would you please introduce her?
Yes. So Dr. Priyanka ma'am is my senior colleague lecturer here. She joined the department 5 years back, and she is one of the pillars of the department. Because I must say that many of the times when there are multiple things that I'm not able to do it, then I rely completely on her, that I know if she is there, then the things will happen. Like OPD is increasing, I know she will manage. There is certain problem, I know she will manage. There are few residents not listening to me, I know she will make them listen. So she is a backbone to me, and a very important colleague and the part of the department to have. I hand over to the Priyanka ma'am.
Yeah, actually, both of them are the two pillars, and Priyanka and Sumit are those buffers in between, and the link between the PGs and the faculty. So, yeah, over to Priyanka.
Thank you so much, Sumit and Sujata madam, for your kind words. First of all, I would like to say Happy Teachers' Day to all my respected teachers, Lane sir, Ragini madam, and all senior teachers. So I'm sharing my screen. I'll be talking on perimetry basic and its field defects in glaucoma. Is my screen visible?
Yes, Priyanka, it is visible.
Okay. So thank you so much. So what basically is visual field is defined as a part of the environment that is visible to a steadily fixing eye, and the altitude of the field, it correlates with the visual sensitivity in a given location. So there is a pit that is called as a physiological blind spot in the island where you don't see any object around there. So Harry Moss Tracker was the one who defined it as an island of vision or hill of vision surrounded by sea of blindness. So as we all know that the visual field is uniocularly, if you see, it is greatest in its temporal part. It's around 100 to 110 degrees. It's in the superior, inferior nasal part, it is around 50 to 60, 70 to 75 degrees and 60 degrees respectively. There is a blind spot which is situated temporally between 10 to 20 degrees. Then the central field of vision is within the 30 degrees of the fixation, and the peripheral field is beyond that 30 degrees. And that's why in glaucoma we evaluate for this central 30 degrees of the visual field, as it is a location for the sensitive retinal nerve fiber lens. So what is perimetry? It's the systemic measurement of the visual field and its function. So it's actually the measurement of hill of the vision, is how amount of light sensitivity of the patient with the different visual stimuli is recorded in a specific manner, and that is called as the perimetry. So what are the indications? We do perimetry or visual field assessment in cases of glaucoma, and also to assess the progression in these cases, to know various choroidal diseases, optic nerve and optic lesions, and also for neuro-ophthalmologic diseases. So there are basically two parts broadly, like kinetic perimetry and static perimetry. Kinetic we used to do previously. Nowadays we are shifted to static perimetry, which includes Humphreys, Octopus, and Oculus. So I'll be discussing on Humphreys perimetry in detail today. So these are a few photographs I could find out that Lister's perimeter. This is Jerem's screen, Goldman perimeter, and this is Humphreys field analyzer. So the difference between the static and kinetic perimetry, the static is computerized, stimulus size is constant here. Whereas in kinetic, the stimulus is moved from a non-seeing area to a seeing area along with a set of meridian. In static, the contrast sensitivity is tested throughout the test. Whereas in kinetic, the speed, size, color, brightness of the target at different variables is tested. So advantage of static or kinetic perimetry is it is quantifiable, reproducible, easy to manipulate. The threshold detection is more sensitive here, and it reduces the need for a highly trained technician. Where the advantages of kinetic perimetry is it's inexpensive, durable machine. Statistical manipulation is a bit difficult, but it's good for patient. That the patient can comfortably do it. It can define scotomas rapidly. Disadvantages of static perimetry is a large amount of unfamiliar data interpretation is difficult, and it's a tedious and a time consuming job. While in the kinetic perimetry, the skill and training is important. Earlier subtle changes can be overlooked. So what is being tested in the perimetry? So we actually test the light sensitivity measured in the different areas of the retina. So physiologically, the fovea, the central part of the retina, is the most sensitive part than the peripheral one. So these light sensitivity which we have measured, which we compare it with the normative database which we have in the machine and which is obtained from the multi-center studies. So here in Humphreys tonometer, we use two units, aposteps and decibel. So apostep is the absolute unit of light intensity, but the manufacturer has converted the aposteps unit into the decibel for the presentation. So the decibel and the aposteps unit are inverse logarithm of each other. So if the brightest light is required to elicit the retinal nerve fiber sensitivity in decibel, it means the retinal real fiber layers are damaged. So it means the 0 decibel is equal to scotoma, and normal sensitivity is around 40 decibels. So in clinical perimetry, the stimulus intensity is varied with fixed size and duration. It determines the minimum intensity at which the patient responds to 50% of the time, which is called as threshold. And the threshold is determined by the bracketing strategy, in which initially we use, like as shown in this picture, initially we use a lighter stimuli, then we elicit how much is the response from the retinal nerve fiber, and we gradually increase the the threshold of the light, and we can get the suprathreshold levels as well as the infrathreshold levels. The another term here is the frequency of seeing the curve. It means that the probability of perceiving the stimulus, it is mapped in a graph as a function of the stimulus luminance. So the threshold for a given point is defined as that stimulus intensity which has a probability of 50% of being seen. So as I have already told that the lower decibel values indicates higher the light intensity required and lower the retinal sensitivity of the particular area. In automated static visual field, we actually test the point pattern and the strategy which is used. So pattern, if we go with the Humphreys visual fields, it has threshold test and screening test. So threshold test are again, we have three types: that's central test, peripheral test, and specialty test. Central we have 30-2, 24-2, 10-2, and macular program. For peripheral, we do 60-2, nasal step and temporal crescent. And for neurologic, we have 20 degrees and 30 degrees test. So point patterns are divided into multiple types based on the extent of the field that is going to be tested by a particular point pattern. The relation of the points to the horizontal and vertical axis, the point density, that the distance between point to point in degrees, number of points to be tested, and degree of bare area around the fixation spot. So here are some patterns we usually do screening or glaucoma testing with. Most commonly used are 30-2 and 24-2. Another pattern which we have is 10-2 and macular point pattern. So the different strategy are used for depending on which case you are dealing with. Like if you're suspecting a glaucoma on your clinical signs, then you can go for a 30-2 CETA standard, or if if the patient is not that much cooperative, you can go for 24-2 CETA standard. For a case of established glaucoma, always do 24-2, and remember, whatever strategy you are using for the baseline, you follow the same strategy on the follow-up, so that it gives a proper idea for comparison, and the progression or the increase in the size of the scotomas or the glaucoma progression can be find out easily. So for advanced glaucoma, it is better to have a 10-2 CETA standard or CETA fast, or you can go for macular program. As in advanced cases, most of the retinal nerve fibers are damaged, and you need to check whether the macular central point fibers are working or not, and whether there is a macular split or not. For any elderly patient who cannot be able to concentrate or cannot sit for a long time, can go for 24-CETA fast. So there are different zones. The field analysis that the printout I have shown here, which is divided into 8 zones for interpretation. I'll be discussing these zones one by one. For the interpretation, you should go step by step. Step 1 is verify whether the patient data and the test data are properly entered. Step 2 is decide whether the test is reliable for that selected patient or not. Then measure the foveal sensitivity, and it should correlate with your visual acuity. Confirm the normal position of blind spot. Analysis of total deviation probability plot and pattern deviation probability plots. Then role of pattern standard deviation glaucoma Hamilton test. Then find out for the deviation numerical plot on the total deviation map, and find out the mean deviation index, and also on the pattern deviation numerical plot. And then finally look for the raw data what we have available. Zone 1 indicates the patient's data and the test data, which it has various parameters like constant and variable. Constant parameters includes fixation monitor, color of the stimulus is usually white, background illumination is around 1.5 absolute. So variable parameters include fixation target, which is usually center. Stimulus size we actually choose for size 3, but if in advanced glaucoma, you can increase the size up to 5. Threshold test and pattern which we are testing. It also mentions about test strategy. Is it a full threshold? It is CETA standard or CETA fast. The pattern used, that is 30-2, 24-2 or 10-2, and patient details like date of birth, date of visual field analysis, then pupil size, time, visual acuity, correlation, and refractive correction, and the eye which is being tested. Zone 2 here indicates the foveal threshold and visual acuity. So recording the foveal threshold is optional, but that is preferably should be turned on, because it gives the internal validation for the visual acuity, and this visual acuity and foveal threshold should correspond. So whenever you're checking with zone 2, you should be able to know that whether the field is reliable or not. We have 3 terms, that is false positive, false negative, and fixation losses here. False positive is the pressing the button even in absence of the visual stimulus. False negative is failure to respond to a threshold stimulus which was previously seen at the same time. If the false positive or false negative parameters are more than 33%, then the field is unreliable. Also, if the fixation losses are more than 20%, then the field becomes unreliable. Then the third zone is gray zone. It actually gives you a rough idea about the scotoma, and it gives about the gross false positive or gross negative errors. Grayscale is not used for the diagnosis of glaucoma. Next is zone 4, which is a total deviation plot. So it is a point-to-point difference between the patient's threshold compared with the normative data. So it gives an overall, it gives an idea of overall sinking of the heel of the vision. As shown in this picture, the yellow line demarcates the normal heel of the vision, whereas the graded area is the patient's visual field, which is generalized depressed. So it could be because of media opacities like cataract, corneal opacity, or refractive, or because of pupillary meiosis if the patient is taking meiotic eye drops. So the total deviation plot also highlights any scotoma that may be present involving a large area of visual field. But this total deviation plot will not give you an idea of hidden scotomas, as it gives overall depression of the visual field. Next zone is zone 5. It is the pattern deviation plot. It gives an idea about the hidden localized scotomas, which are very characteristic of glaucoma. So the pattern deviation plot also gives a numerical as well as a probability values. So if there are abnormal points in total deviation plot, and if those abnormal point persist in the pattern deviation, then it means it is a localized defect and it is usually glaucomatous. So if there is no scotoma on the pattern deviation map, but you see scotomas on the total deviation plot, then it is because of media opacity or other pathologies. See here you can see in the first picture the scotoma in the total deviation plot, and the scotoma is seen on the pattern deviation plot, and that is called as a localized defect. In the second picture, you can see a total scotomas in the total deviation plot, but which is not seen on the pattern deviation. So this is called as uniform generalized defect. There are few defects which are called as irregular generalized, means they are seen both on the total deviation plot as well as on the pattern deviation, but they are not similar, they're different. So they are called as irregular generalized defects. The sixth zone we see is an important part, and that it gives you an idea about the global indices, which includes mean deviation. So the mean deviation is derived from the total deviation plot. A positive number indicates it's a better than the normal field. That's the elevation of the heel of the region. A negative number is depression of the heel of the region, and it could be because of cataract opacity, corneal opacity, refractive errors, or pilocarpine like meiotic drugs. A large scotoma produce a negative mean of deviation. The mean deviation usually high in generalized field defects, while in localized field defects it is not high, but it depends on the depth of the scotoma or the extent and depth of the field defect. Other parameter is pattern standard deviation. It is with significant p-value, can either be a pure localized field defect or a localized field defect in a generalized depression. So there are other indices like short-term fluctuation and corrected pattern deviation, which are used in fast-pack strategies. In short-term fluctuation, 0 to 2 decibel is normal. More than around 2 to 3, early damage is around 2 to 3, and 3 to 4 indicates moderate damage. More than 4 is advanced glaucomatous damage. So corrected pattern deviation is derived from the intra-test variability, and it's obtained from the pattern standard deviation. Zone 7, it's a glaucoma Hennefeld test. It compares the 5 mirrors in upper and lower fields. A score assigned to each zone based on the location of the zones and the deviation values in the pattern deviation numerical plot. So what results we get in this zone is, it could be either outside normal limit, could be borderline, generalized reduction of the sensitivity, abnormally high sensitivity, or a normal GHD. So how to interpret the visual field in cases of glaucoma? First of all, assess whether the nerve fiber, it assess the nerve fiber bundle damage at the disc. Also the area of loss of visual sensitivity supplied by the RNFL, and the scotoma which is localized or generalized. So as you can see here that central 10 degrees indicates the central fixation, that it's demarcated by yellow circle. The red circle is a 20 degree. The outer black circle indicates 30 degree of your central field, and these points are 6 degrees apart. So 10 degree visual field does not include the optic nerve, it includes only the fovea. So there are typical characters of glaucoma field defects. They are almost always localized. They respect to the horizontal meridian. They usually begin nasal to the blind spot. The upper pole is affected more oftenly than the lower part. They are detectable within the central 30 degrees of the field, and they are reproducible. So these are various field defects. The first one is a nasal stip, then temporal wedge, then superior arcuate, early paracentral defect, the superior fixation threatening paracentral defect, the superior arcuate with peripheral breakthrough and early inferior defect, the tunnel vision defect with temporal crescent sparing, and the complete field loss. So we follow the Anderson's criteria for glaucomatous field defect, which includes first that the abnormal glaucoma hemifield test. Second point is more than 3 contiguous non-edge points in the location typical of glaucoma on the 30-2 printout, or edge points on 24-2 printout with p value less than 5%, of which at least one has a p value less than 1%. And on the 30-2, nasal edge points are also included for the classification. PSD or CSPD should be abnormal and should have a p value of less than 5%. These are few perimetry printouts, like this field suggests of early paracentral scotoma. You can see the scotoma next to the central part. Early nasal stip. Nasal stip is the earliest field defect you can see in glaucoma. Here the mean deviation is minus 2.46, PSD is 2.63, and you can see scotomas opposite to the blind spot. This is moderate superior scotoma. It is moderate because the mean deviation is minus 9. So if the mean deviation is around minus 6, it is early glaucoma. Minus 6 to minus 12 is moderate glaucoma, and more than minus 12 is advanced glaucoma. This is advanced superior arcuate scotoma. This is double arcuate scotoma with temporal sparing. In this printout, you can see a tunnel vision because only the central part is seen in the 30-2. In this, I have these 2 printouts. In the first left-hand side, you can see a total the tunnel vision, but there is no scotoma seen on the pattern deviation. It is because it is done with the 30-2 and that's -2 strategy, and there are not enough retinal nerve fiber layers to produce the scotoma over here. So it is better to go for a 10-2 program. So the same case, if you do with 10-2, you can see a double arcuate scotoma here. So this is what actually should be done in advanced glaucoma. This printout shows both focal as well as diffuse defects. You can see lens artifacts as a rim effect in this printout. A patient with ptosis can show a scotoma superiorly, which correlate with the grayscale as well as with the total and pattern deviation. If you tape the upper lid, you can get a normal visual fields. This was all about glaucomatous field defects. Thank you.
Yeah, thank you, Priyanka, for that good illustration, and I'm sure this will help all the PG students because this is one of the table vivas to read a printout of the perimetry report.
Yes.
Sumit, do we have the next presenter?
Thank you, Priyanka. Wonderful. It is as detailed and meticulous and hardworking as you are. Thank you so much for the lovely teaching.
Thank you so much, madam. Thank you.
Yes, madam.
Ragini, madam, your voice is, yeah.
Yeah, Priyanka, will you stop sharing here? Dr. Sujata, anybody would say something? Rahul, Dr. Vavikar?
Yeah, hello, madam.
Priyanka,
Hi,
very
Rahul.
nicely done.
Yeah.
Good practical tips for the students. And always she is, more like a friend to the PGs rather than a teacher. She always knows how to get the work done in a very effective way. And the presentation was good. I think she covered everything there, especially, this when they struggle with this diagnosis, whether, they go for another test or no. I think you explained that pretty well in order to that, okay, at this point of time, you need to go for a 10-2 and not just restrict yourself to the. So that was very well handled. Thanks so much.
Thank you, madam. Thank you, sir.
Excellent presentation it was.
Thank you, sir. Thank you so much.
Ragini, madam, do we have Amruta presenting?
Yes, Amruta is there. Amruta?
Yes, madam. Good afternoon, ma'am. Yes, ma'am, I'm there. Can I share my screen, ma'am?
Yeah. So I welcome Dr. Amruta. Dr. Amruta again is a very integral part of the Vitreoretina department at JJ Hospital. She has done her Vitreoretina fellowship from JJ Hospital. She's done her postgrad from Nair Hospital, and very hardworking, always on her feet, always running up to do everything which is she's there for the patients always. So Dr. Amruta, over to you, and her presentation is about some interesting cases on retina. So it's titled "What Will You Do?" Go ahead, start, Dr. Amruta.
Thank you, Pritam sir, and good afternoon, respected sir, Ragini madam, Pritam sir, and BOA, and thank you for giving me this opportunity. And happy Teachers Day to all the teachers, respected teachers who are present right now. So today I would like to discuss two cases which are of macular edema and how to approach them. So the first case, it was a 56-year-old male patient came with a diminution of vision in left eye since few days. It was a history of cataract surgery with PCIOL 1 month back. There was no systemic illness or trauma. On the day 1 of the post-op, vision was finger counting 5 meters. There was thin pupillary membrane. Cornea was clear. AC was formed with minimal reaction, and IOP was normal. He was given short course of oral steroids and topical antibiotic steroids and mydriatic drops. On post-op 1 week, the left eye vision was improving to 618 with a refraction of -2 sphere with -2 cylinder at 180s. The anterior segment, the PCIOL was seen in the sulcus, inferiorly decentered, and rest anterior segment appeared normal. The fundus showed anterior vitreous haze with the visible retina normal. Patient asked to continue with the same medications, but again he lost the follow-up and came with a sudden diminution of vision since 2 days after a month and a half. So on this follow-up, the vision was finger counting 5 meters, which was not improving on pinhole. PCIOL was inferiorly decentered. Other AC appeared normal. The fundus, few anterior vitreous opacities, retina was normal, but FR was dull. And in this time, the IOP has raised to 24 millimeters of etching. The fundus photo and OCT of macula showed CME. So in view of raised IOP, how will you proceed and treat this CME? So this was a fundus photo of left eye showing the foveal reflex was lost. And then we did a OCT of macula, which shows a significant cystoid macular edema, which was suggestive of a pseudophakic CME in view of no systemic illness to the patient. So we again started the patient on anti-glaucoma drugs, and considering the inflammation, we avoided the prostaglandin analog, and we given the normal routine anti-glaucoma drugs and started him on topical steroids. So the question is how long we can wait and observe this CME. So since 1 month has already passed, so we can give a trial of PST, but under a control of glaucoma, anti-glaucoma drugs. And secondly, the component of UGH has to be ruled out because the IOL was decentered. So in that case, UBM would be helpful to see whether there is any component of uveitis glaucoma syndrome is there or not. And if that is the case, and that is the primary cause of this kind of edema, then the subluxated IOL has to be removed and the further management has to be done. So this was the first case. The second case is of again a macular edema. The 60-year-old male patient came with a chief complaint of diminution of vision in the right eye since a month. History of cataract surgery with PCIOL, which was uneventful a month back outside. Patient was referred to us. Patient was a known case of type 2 diabetes since 7 to 8 years, on oral hypoglycemic agents. On the right eye vision on post-op day 1, which was noticed, was 660 with anterior segment quiet. The fundus was showing moderate NPDR with dull FR. The patient was started on, again, topical antibiotic steroid drops, the way we start the post-operative. At 1 month post-op, there is no improvement in the vision, even with the refraction. And vision was same as on the first follow-up. The fundus again showed the moderate NPDR with dull FR. The fundus photo and OCT macula are shown here. Now here on the fundus photo of right eye is showing a moderate NPDR and dull FR. So we did a OCT, which was showing a significant macular edema with a lot of hard exudates. So mostly it is a DME, which is a diabetic macular edema. The patient is actually referred to us from outside. So the pre-op fundus findings and the OCT pictures are not available with us. So considering the patient is a diabetic patient on oral hypoglycemic since 7 to 8 years, so we will treat this as a DME rather than a pseudophakic CME, and we'll go with anti-VEGF injections to resolve this edema. You can give a trial of this anti-VEGF injections for this patient. So thank you. These were the 2 cases of macular edema which were approached. So thank you, sir.
Thank you, Amruta. Thank you very much.
Thank you, ma'am.
Dr. Amruta, what was your provisional diagnosis in the first case?
Provisional diagnosis first case was the patient was showing actually diminution of vision, which was not improving, and the actually the AC was showing little of inflammatory component to it, like mild like thin pupillary membrane, and fundus was seen with FR. So it is maybe there was no hypopion, so I could not think of any TAS or anything. So it was an inflammatory inflammation, basically post-op inflammation. So we started.
Right? There were vitreous opacities also, right?
Anti-vitreous opacities, but the rest retina was appearing normal. The mid-vitreous and the posterior vitreous and the retina, there was no exudates or anything, and it was clear. The media was clear.
Can it be mild TAS?
So TAS actually it occurs within 24 hours, and there is a component of like hypopion, and it usually resolves with steroid topical steroids.
Yeah, here what has happened, patient developed the same reaction after 1.5 months. Probably that is the time the steroids were withdrawn, and that is
Yes,
why
sir.
the reaction surfaced again. And
Yes, sir, he lost the follow-up also. Yes, sir.
You don't know what happened in the end because patient lost the follow-up.
Yes, the patient lost to follow-up after like 1 week because of the lockdown and things, and he was referred to us in view of diminution of vision.
Excellent. And in the second case, pre-operative, I know it is not your case, it was referred to you, but would the pre-op OCT or immediate post-op OCT would have helped in diagnosis and treatment?
Yes, so the pre-op OCT in the fundus would have been seen, and it again depends upon the grade of the cataract, sir. If the fundus was not visible and the OCT findings also would not be very accurate if the cataract was advanced cataract. But definitely pre-op fundus evaluation and OCT would have definitely helped in this case. If we would have diagnosed the DME beforehand, then maybe before the cataract surgery or during the cataract surgery, the anti-VEGF injection could have been given. So.
Yes, even immediate post-op, when the media had become clear because of the removal of the cataract, the patient's vision was only 660. Even that time, OCT would have helped, right?
Yes, sir.
Can I say something?
Yes, ma'am.
See, your first case was clearly a case where there was a kind of disturbance during the cataract surgery because you had like kind of inferiorly displaced IOL, and obviously that was kind of probably causing some iris touch, some push at the angle, and that was probably the reason for the irritation, inflammation, and the slightly elevated pressure. Now, since your pressures were high, you would not like to put the patient on topical steroids, so best would be to go in for some NSAID drops, but you could start oral steroid to get hold of the inflammation, and after that it would require a repositioning of an IOL or putting in an IOL in a different location or securing it, because obviously it is the irritation from the haptics probably which is causing this whole problem, coupled with your anti-VEGF, your non-steroidal drops for about 3 to 4 months. And if, that would be the first line of action in the first case. And in the second case, it's clearly a patient where you've had a diabetic process in the background. So I do not know whether a evaluation was done pre-op, because if there was a prevalent diabetes or a diabetic edema earlier to the cataract, and if it was not tended to, it could have landed up with a worse effect after the surgery. But at this point of time, what you need to do is an FFA for the patient to know whether there are any leakages and what is the other lesions. And anti-VEGF is helpful, but you can couple it with a laser treatment also for the peripheral lesions.
Yes, ma'am. Thank you, ma'am, for all the valuable suggestions in these cases.
Thank you very much, Priyanka. Madam, with that, should we give the concluding remarks?
Yes, Swapnesh. Pritam.
Yes.
Swapnesh, concluding remarks.
Concluding remarks, your forte.
Sure. So thank you everybody for participating on a Sunday. I should say afternoon now, in this first ever Gurukul webinar, and it was very apt to start from JJ Hospital. And thank you, Lahane sir, for sparing time from your busy schedule, madam for encouraging us, and Pritam sir for guiding us. Thank you all the moderators, Avikar sir, Rahul sir, Sujata madam, Karobi madam for staying back. And thank you all the speakers for enthusiastically presenting. I would like to also thank Numorotech for giving us this platform at the last minute and having a very absolutely a smooth streaming. The same sessions would be available on the YouTube as well as the Facebook. And next month, we are proud to announce that the Gurukul will move on to Shankar Netralaya, Chennai. And mostly we have a confirmation about the November Gurukul also, where RP Center AIMS would be participating. So here, a big cheers to a great beginning. Thank you, madam, and thank you, Pritam sir. Thank you, Lahane sir.
So अपने गुरुकुल में खाना मिलता है क्या?
So I think we made a mistake. वो जो बीच में एक AIOS का या कुछ webinar था, उसमें lunch बेचते हैं. So I think we should do something like that. Swapnesh was telling me last time for the BOA symposium, but I thought it was too much work. And happy Sunday, everybody. Thank you.
Bhavikar sir's screen share is that beach. So next time we'll have a screen share for everyone with food on it.
Bhavikar is going for a swim after this.
Thank you. Thank you, ma'am. Thank you, Vavi.
It was lovely being here with all of you.
Thank you, everybody.
Thank you, sir, and thank you, madam.
Thank you to all the teachers.
Thank you, Lahane, sir.
Thank you, sir.
Thank you, all the teachers. Thank you, everybody.
Thank you.
Thank you, all my teachers. Thank you, Lahane sir. Thank you, Ragini madam, for being the best teacher.
Thank you, Pritam. Thank you, Swapnesh. Swapnesh, this is a wonderful idea.
Yeah, very good idea. Really.
Yeah.
Yeah.
So Vavi has really put a screen for us to see the beach.
I know. He's going for a swim just now.
He came from swimming.
When Vavi used to tell me this suture is not
He came
correct.
from swimming. Just now came from swimming.
But unlike Dr. Bhatti, he's worn clothes.
He's so honest about it, no, that I'm not putting on my video because I am in my Sunday.
No. I'll tell you something. Truly, it's not because he's wearing shorts. It's because he mustn't have combed his hair.
And we forced Deepak, but so I think he must have quickly worn his shirt and come.
Thank you so much. It was lovely being with you all on a Sunday morning.
So, ma'am, you are JJ alumni. Vavi, you, Rahul.
Everybody.
Thank you, madam.
Everybody from JJ.
Thank you.
Thank you. Bye, PP.
Bye. Bye, Kobe.
Bye, sir.
Thank you.
Bye,
Bye,
Ragini.
bye, ma. Thank you so much.
Welcome.
Bye, ma'am.
Bye.
Bye, Sujata.
Bye, Sujata.
Thank you, ma'am. Bye-bye.
Bye, madam. Madam, see you
Bye,
tomorrow.
Rahul. Bye, Peter.
Bye, madam. Bye, madam.
Bye.
Madam, see you tomorrow. Bye.
Bye, Rahul. See you
Bye,
tomorrow.
madam. Bye, sir. Bye. Happy Teachers' Day.
Happy Teachers' Day.
Thank you.